Welcome to the RP Centre ORA Cataract CME, organized under the aegis of Ophthalmic Research Association, RP Centre, AIIMS, New Delhi. The chairperson for today's meeting is Professor Jeevan S. Tityal, co-chairpersons Professor Radhika Tandon, Professor Sudarshan Khokhar. Moderator will be Professor Namrata Sharma, Professor at RP Centre, AIIMS. And we have two esteemed guest speakers with us, Dr. Sudhang Bharti, Medical Director, Bharti Eye Foundation, and Dr. Tinku Bali from Sri Gangaram Eye Hospital, Delhi. And we have a host of RP Centre faculty who will be there with us as panelists and speakers, Professor Tushar Agarwal, Professor Rajesh Sinha, Professor Vanathi, Dr. Nupur Gupta, Dr. Praful Maharana, Dr. Manpreet Kaur, and Dr. Sridevi Nair. I now hand over to Professor Jeevan S. Tityal, Chief RP Centre, to give the welcoming remarks and start the CME.
Yeah, thank you, Manpreet. Indeed, it is my pleasure to welcome everybody who have joined us today for this CME on cataract, as well as like to welcome the two our guest faculties, Dr. Bharti and Tinku. Been a part of many long associations with RP Centre and all academic exercises. Thank you, both of you, and faculty of RP Centre who have joined today for this exercise on a cataract. I'll say exercise because cataract everybody does, but to learn something extra is exercise, because you have to put your mind, your techniques, your thinking into a subject so that you get something out of these common presentations. I'm pretty sure we are going to do justice to people who are going to join us. On behalf of RP Centre, the faculty, the students, and the ORA Ophthalmic Research Association of RP Centre, I'd like to welcome all of you. Hope that we have a very nice interactive session. Thank you, Manpreet. I think Dr. Namrata can take over as a moderator now.
Thank you, sir. It is a pleasure to moderate the session today, which is going to be on cataract. And we have a galaxy of speakers with us with talks as well as panelists who will contribute in between. It is my pleasure and honor to request Professor Jeevan Singh Tityal, sir, Chief of RP Centre and President of the Ophthalmic Research Association, to give his talk on IOCT in challenging cataract cases.
Thank you, Professor Namrata. Indeed, we should have nice, starting or beginning. Nothing better than something which makes things look better and more visible, not only for surgeons, for our patients also after going through these surgeries. And we know that there has been a new concept in the integration of optical coherence tomography in the microscopes. We all know that came up because of retinal surgeries, or making more a prominent visualization of retinal imaging and surgeries. But it has translated to a very nice assistance to anti-segment surgeons also, more so in a corneal surgeries, and to some extent the cataract surgery also. Today I'm going to highlight two of the challenging situation on a cataract surgery where we might use IOCT to increase our visibility in these cases. I have no financial disclosure for this particular talk. And we all know microscope integration in with the OCT will definitely enhance two things. One is it will make you understand the intraoperative dynamics of each step of your surgery, or initiation of any step will make you feel, understand, see what is happening with every surgical step you are taking in your cataract surgery. Therefore, it will be helpful to a normal surgeries, but more so in a challenging cataract surgery also. And this is our review article in IGO, which has a open access. People can go through that. The first thing I'll like to talk about is our challenging cataract cases. We all know absence of reflex in these cases of white cataract makes cataract surgery difficult, because initiation of capsular access is difficult. And most of the time it is incomplete in many situations. And the major concern for all of us has been the raised intralenticular pressure, which may be seen in some of the white cataracts, where the chances of rhexis extension is much higher. And once it happens, there's always a difficulty in completion of surgery in these cases. The third important thing is, especially in a hypermature cataract, there's a lack of a epinuclear cortical cushion in these cases, which will expose the posterior capsule right from the beginning of your nucleotomy, and there would be more chances of a capsule getting ruptured during your nucleotomy procedure, because sometimes that capsule may be little more, you can say flexible or more lax, which can come into your port, especially if your fluidics are not proper in these cases when you have surgeon, especially towards the end of nucleotomy. So this is what we worked on to look into the advantage of IOCT in wide cataracts, to look into a real-time intraoperative dynamics in these cases, which could be seen in these images. You can see we have divided into 4 types of wide cataracts, and you can have a spectrum in between also. If you see here, type 1, we have a various spectrum also. Similarly, type 2, type 3, and type 4. On what basis we could classify it in the 4 areas? So we had 7 important points to be considered in these cataract cases. The 3 things which I have highlighted in green can be seen with your examination of slit lamp or anti-subclinic OCT. That is the convexity of anterior lens capsule, the arrangements of lamellae of cortical fibers, and the interlenticular clefts, fluid pockets, or you can see a homogeneous appearance of a liquefied cortex. This we can appreciate in a direct examination. What is not visible is the dynamics. These are red points here. The flattening of anterior lens capsule when you inject a viscoelastic, the regularity of flattening, the dynamics of capsule or a subcapsular material, that is a fluid or a cortex after initiation of initial capsulotomy or capsular access, and the disturbance of underlying cortex and the release of fluid that may be turbid or milky, or there may not be any release, or there may be a bulge of cortical fibers. So these 7 points are critical in classifying your wide cataract preoperatively with examination or intraoperatively. So this is what we have classified type 1, where you can see there's not much of a convexity. You can have a uniform, you can say reflex coming off of fibers, not much of intralenticular pockets. Therefore, this cataract may not have a raised interlenticular pressure. As soon as we initiate the capsular access, you can see it is all flat. You can do a nice capsular access initiation without the fear of extension. And you can achieve this with needle cystotome or your microforceps in completion of access. So these are cases of a senile age-related cataract, which is advanced into the stage. Ultimately, this will go into hypermaturity. This is type 2 wide cataract, which is seen a younger patient with a rapid onset most of the times. You can see the convexity is much more. You can see a continuous hyperreflective bands or sheets of cortical fibers, and in between them you have a clefts of fluid. So these are ultimately covered by these sheets of cortical fibers. And you can see after we initiate the capsulotomy opening, small one, there's no fluid release, no leakage of fluid in these type of cataracts. There's a definite bulge of these cortical fibers because the anterior pressure that got released, and there's a pressure from behind which is pushing the cortical fibers up. But definitely there you can see these clefts are still on, that therefore they had not been released. So these cases will be difficult to aspirate by needle. You require a different procedure to be done. That is a bimanual aspiration of cortical fibers rather than fluid in these cases to decrease. Just to represent a video from a type 2 type of wide cataract, you can see after initiation, there is no release of fluid and the rhexis would tend to go to periphery. You can see this is a mountain of the raised lenticular fibers, where after injecting dispersive viscoelastic to flatten, you need to complete the small rhexis, then aspirate the hydrated cortex and make the entire capsular diaphragm go concave, and you can complete the rhexis of desired size in these cases. So 3 important things we have learned in these type of cataracts. There's a bulge and the clefts are not opened up. These cases will have a high incidence of peripheral extension. You have to aspirate the cortical fiber rather than fluid in these cases. So that is important learning in these cases. Type 3 is where you have a cortical fibers which are broken, and you have an intermingled clefts as well as the homogeneous fluid also. So this is type 2 going to type 3. In these cases, the convexity is there. But as soon as we inject a viscoelastic, the concave convexity goes down. That indicates the pressure may be less. Initiation of opening the capsule will have a release of a milky or a sort of oily fluid coming in these cases. So this is the just beginning of milking. This is got an oily fluid coming out. As soon as it gets released, the pressure goes down. And you can see you can aspirate this type of cataract with a needle also, or you can do a spiral access, or you can aspirate also with the bimanual cannula in these cases. This is type 4, where entire cortex has got liquefied. The entire thing is replaced by the homogeneous fluid, which as soon as you make a puncture, the milky fluid will come out and the pressure will go down. The difficulty here is once you have the fluid coming out, the pressure from behind for a completion axis gets distorted because there's no support from behind. So you may have to increase the pressure by injecting viscoelastic, or you mobilize the nucleus to the area where you're doing actual tearing in these cases. The forceps related capsular access will be better in these situations. So you have type 1 to type 4, and in between you have a various spectrum of white cataracts. Type 2, as I said, is in a younger patient with a rapid onset. These patients have a thick hydrated cortical fiber extending from one side to other corner of a lens. Doesn't let fluid come out, therefore release of pressure is less in these cases. Type 4, it's totally fluid, the other side of spectrum of white cataract. And the dynamics of initiation of capsular access can be picked up by IOCT microscope only. The second area which I like to highlight is the difficult cases which is in the posterior polar cataract. There also IOCT has a significant role in improvising your surgical technique and improving your surgical outcome also in these cases. So these are various clinical presentations where we are not sure what is the posterior capsular status behind this posterior polar disc. So you can see these are various types. Some cases look like a posterior subcapsular cataract. So this is a definite extension of a posterior, you can say, pole of a cataract going to the deeper areas. This is the typical onion peel appearance of white cataract. So anti-segment OCT can give you a delineation of various types of posterior polar cataract, and we can pick up the difficult anti-segment morphology by this OCT pictures. So this is a study published by my younger colleague, Dr. Amar Pujari, where he delineated the difficult morphology. These are the morphology where chances of posterior capsular defect or a rupture intraoperatively much higher. So he described 3 types. One is a conical morphology or a moth-eaten morphology. Then you have an eclectic morphology. These 3 types of cases seen in a less number of cases, like 9% of cases. If you have this type of appearance, then you have more chances of posterior capsular adhesions happening during the intra procedure. Same thing we described by IOCT also, similar picturization. You can see type 1, type 3, and type 4 based on a similar imaging of the posterior capsule. The type 1 in those cases where you have a posterior polar cataract, but you can still delineate the entire length of a posterior capsule underneath the disc also. And surgery becomes simpler in these cases because we know that posterior capsule is intact in these cases. So in fact, you can do a hydrodelineation like this. You can see the delineation has been done. There will be a definite space coming up, and this is the epicortical cushion, and this is the posterior polar disc. So this is what delineates the endonucleus, and subsequent surgery becomes simpler. And these are cases sometimes you can just do a hydro wave without rotation, and your surgery becomes faster and simpler, and the surgery becomes safer in these cases. Type 2 is where you, as I showed where delineation in the middle area may be difficult. Type 3 is the most difficult cases where delineation right from the periphery to center is difficult for a posterior capsule. The chances of tear in these cases are much higher. So this is a type 3 type of posterior polar cataract. You can see a onion ring-like appearance, around 4 millimeters the disc size. Larger the disc size, more of the chances of adhesions happening in these patients. So I'll go a little faster. You can do a normal size axis around 4 millimeter. So we have just done a hydro delineation here, avoided hydro dissection. So you have to do a little bit of trench. This was a grade 2 plus nucleotomy, the nucleus hardness. Then chop it because rotation may not be possible. So you have to take out this chunk of nucleus, a pie shape, So this will give us space for an internal hydrodelineation happening in these cases. So I've taken out one area. This is the second block which will be taken out. Then maybe the rotation may be possible because the fluid would have entered in at this stage. So you can see the rotation has happened because the delineation is allowed by the internal hydrodelineation in these cases. So if I go a little further now, I can see that nucleus has been complete. Now I have a larger nucleus, epinucleus core here. So sometimes you have to break this also for a delineation to be completed for this core. Then you can take out entire thing. But you can see the posterior capsule has opened out because this was a type 3. But you can still do it because vitreous bulge in the posterior polar cataract is less likely if you maintain the anterior chamber pressure. So I have withdrawn my second instrument. I'll show it again. I remove this cortical fiber. Now I'll remove my second handpiece, maintain the pressure, and inject the dispersive viscoelastic. So this will maintain the pressure, would allow the vitreous to come out. Then you can complete the aspiration, then inject the IOL, which should be perpendicular to this tear, and it can settle down. So this is how safely you can complete in those cases where you have a rupture also. Then subsequently, you can do a bimanual aspiration and complete the surgery in these cases also. This is type 4 type of cataract, which is seen much more in a posterior cases with a congenital type of variety of posterior polar cataract, where you have the defect in the posterior pole. You can see a conical shaped of type or a sort of pouch type of posterior capsule in these cases, which may have a granulation like a whitish deposition happening in the capsule, as well as in the anterior vitreous face, which earlier had been described with a fishtail sign by Dr. Daljit Singh. So here I will complete my emulsification, and this is towards the end of emulsification. You can see there is the whitish deposition in the posterior capsule, and the pouch is still intact. You can see here in the IOCT microscope. So it gives me a courage that everything is intact here. So I can just inject the dispersive viscoelastic, maintain the pressure, then inject the IOL, and subsequently either we could have done the primary capsular access here, because this is a debris which may be there in anterior vitreous also. So I thought maybe I can implant the IOL with little enlargement of inject the lens over the rhexis, and make sure you don't do a wound-assisted injection in a weaker posterior capsule, because you can go into the capsule and damage the capsule at that stage. Then subsequently, after injection, I do a vitrector-assisted opening of this membrane and the whitish deposit which is there in anterior vitreous, so that I have a clear now visual access for this particular case. So this is how you manage these cases. OCT attachment in the femtosecond also give you a delineation of an entire this thing. So this is an OCT picture of a white cataract. You can see the homogeneous appearance of a milky fluid cataract. So these are cases where as soon as we initiate the laser, the milky fluid comes out and pressure gets released in these cases. The same case after milk comes out, if you see in the operating table of this patient, so there will be a definite fibers also. You can see the fibers are still there. The fluid has come out. The surgery now becomes simpler because the pressure has gone down in these patients. The posterior polar cataract can be classified with IOCT. You can change your management protocol in the type 1, type 2, type 3, type 4, and come out with a much better results in these cases. This is the last case scenario where IOCT is also helpful in the difficult cases like incision-related problems. So this is one case of a Fuchs endothelial dystrophy, deep-set eye, non-dilating pupil. I could complete the phaco effectively in this particular case. You can see now injected with IOL, doing an aspiration. You can see the dots in the endothelium in these cases, which is basically the cutter changes. The hydration is complete. If you don't have IOCT, you would have missed this. You can see, I can see the IOCT, the entire descemal membrane has got detached in the wound area. I thought, let me see if it is there in the wound or it is gone to towards the paracentral area also. I just shifted my cursor and you can see the entire descemal is detached. If you leave it at this stage, the next day cornea will be white with a total detachment. So we could manage this patient by injecting the air tamponade for 5 minutes, and successfully the descemal membrane got attached. So these are advantages you see with the IOCT microscopes. And we know that if you have Visibility intraoperatively, you can assess the dynamics, what is happening with each step of your initiation of surgical instrumentation. Definitely, it will be helpful to all type of cataract surgeries, much more in difficult case situations where you can come out with better management for these cases. Thank you for kind listening. I appreciate people who have joined us today.
Thank you, sir, for illustrating so well through the intraoperative OCT microscope, the intraocular dynamics, which I think we miss when we don't have the intraop OCT. And thank you so much for all the novel understanding of posterior polar cataract, white cataract, and the incisions as such on the intraop OCT microscope. Any of the panelists would like to comment or say something?
Just want to ask from sir's experience, actually. Sometimes maybe in IOCT, if there is no defect in a posterior polar cataract, but if the capsule is thin, because most of these PPCs, they have thin capsule in the center, thinner than normal. So would you like to do a hydrodissection, or would you not like to? Would you just do with a full precaution of PPC?
Normally, classical teaching is we all teach, don't do a hydrodissection in all types of posterior polar cataracts. I think that still stands for, most of us. It is only when you have actual assessment for these patients. If I see that posterior pole is clearly delineated, so you might do just a wave and no rotation, because rotation at that stage can still be a difficult situation. So if I have a type 1 type of posterior polar cataract, which I would have seen anti-segment OCT pre-op also, that might initiate the little wave in these cases without rotation, especially in those cases where other eye is a good pseudophakic. If you have always the opportunity to see the other eye, if other eye has a very nice pseudophakia, I'm pretty sure you'll have a less chances of a problem in these other eye which you're going to operate in. Difficulty arises when other eye has a total cataract and you can't assess anything. There it is difficult, or other eye has a poor pseudophakia like ACIOL or thing. Then you need to be very, very careful in these cases. Avoid hydrodissection, just do delineation. And the described technique by Dr. Bajpayee et al. Do a layer by layer phaco in these cases, and that is the perfect teaching for all the beginners.
So just one more question, sir. Moving away from IOCT, many times in these PPCs you do get some few cells, few fibers attached at the posterior pole, even after.
Then I got your question, Rajesh. If you leave it, I think that's the best way. If you have little dots or fibers, don't try to polish it, because it will definitely open up. But sometimes, like type person like me, I would like to do a touch in the posterior pole and it opens up. The most of the posterior polar cataracts where opening has happened of a posterior capsule is during the either irrigation aspiration of viscoelastic beyond the eye, behind the eye vein, or you're trying to polish that, and that is the stage where you become more confident. You have done a good nucleotomy, you implanted eye veil, and you create the opening in these cases. And I've seen one video from I think Dr. Abhay Basavada, where he tries to hydrate the wound area with a little more pressure, and the capsule opens up. So every stage is difficult until the patient is comes out of your table. Nothing is safe in a posterior polar cataract. Okay. Next, Namrata.
Sir, there is a question.
Yeah.
So there is a question for you by Dr. Sanjeet Saha, and he wants to know, is there any learning curve or any difficulty on the intraop OCT surgeries when you do, or I think what he means perhaps is there a learning curve to it? Do you have to modify your thought process in some manner when you're doing these surgeries under intraop OCT microscope?
Definitely, yes. For any new procedure or a new setup you do have a little bit of getting the what do you call the acclimatization or getting adaptation to a that new situation. It may be a microscope, it may be your table or your surgical technique also. This has a little learning curve, not much for us, people who are experienced surgeons. And the difference here is your hand-eye coordination is similar. Only thing, your position of looking at the monitor changes because you're looking upwards rather than looking down towards the ocular. But that difficulty doesn't last more than few cases. And by the time you get used to, your hand coordination becomes simpler. The only tip I can give is you have to always keep your monitor and your table in the same constant area. That will only happen if you have a fixed monitor and a table, so that your the angulation between the working area and your eye area doesn't increase more than 15 degrees. So that is important. If you have more than 15 degrees, then your neck will have a difficulty. It should be around 10 degree or less, so that you still have the same feeling. So not much of learning curve, because the device we have is actually, not only for a posterior segment surgery, it is also meant for anterior segment surgery. The lag which you talk about in this is hardly anything, less than 30, I think, milliseconds. And you have a similar picture as what you have seen. In fact, you have an advantage working in this, digital microscopes where you are off oculars. Higher magnification, better, visibility, and depth perception is also better in these cases.
Thank you, sir. I think with this, we move on to the next speaker, who's none other than Professor Sudarshan Khokar, who is going to be talking about yet another very complex situation, and that is phacoemulsification in subluxated cataracts.
Thank you, Namrata. Can you guys see my slides?
Yes, sir.
After what century hit by Dr. Titial with all these gizmos and all these high-end machines, I think let me see if I can do justice in my being here and talking to you guys today on the cold winter evening. Okay, so subluxated lenses, right? So I'll be discussing more on techniques rather than technology. Technologies, okay, I got 7 minutes warning. Yeah, good. I'll look at that. Okay, so here I go. So the etiology of the subluxation could be a traumatic, spontaneous, or hereditary. Easy to remember, TSH, traumatic, hereditary, and spontaneous. Spontaneous, when I say like high myopia, pseudoexfoliation, cases of glaucoma in which you've done a trab or you've done a DLCP and cyclocryo, you will be surprised sometimes to find these lenses hanging down into the vitreous. Okay, so the traumatic ones would typically come with a picture like this, in which actually you can see hyphema, you can have the sphincteric tears, you can have a lens which is being tilted backwards, the vitreous showing at the edge. Or you can have simple ones which are soft cataracts, something like a Marfan's or a Beal syndrome. Okay, so when you want to do surgical, the approach of surgical has to be depending on the luxation of the lens, amount of the luxation, presence of, and grade of the cataract. If the cataract is harder, you have to change your parameters and you have to put more eye soaks. I'll just give you a basic concept of what is the basic concept of these surgery and how you should go about. So minimum cataract, advanced cataract. So basically what you need to buy when you want to go do this surgery is you want to have some capsular fixation devices. Now, there are two kinds of devices. A few things you need when you're doing the surgery. Few things you need to put a permanent stitch onto the sclera so that these lenses, which are progressive disorders, stay stuck onto the sclera forever. So you basically create zonules which are there forever throughout the life. Okay. So basically, you can see three things. One is a trampoline concept. I'll just tell you what that means. If that concept is clear, anybody can manage these cases pretty well. Okay, so let's go here. Okay, so what you see here is this was a luxation. And you put in a CTR here. And the CTR actually takes the strength from the intact zonules, gives to the other edge, the ones which are broken. And this was the case for which I was called, in which there's a luxation noted, and you see the luxation gone back, all the vitreous is there. After you put in a CTR, you can actually go and cut the vitreous and constrict the pupil and see how it behaves. And the lens looks pretty set. Okay, now this is what I was trying to say when I say trampoline. So this is what is the back capsule of yours. And if the zonules are broken, for trampoline, you can actually buy a springs and you can replace the springs, which you can't do on the human eye. And if you can get these one, I think you should get a Nobel Prize for this one. And that's what you can stretch it out. So during the surgery, how do you stretch it out? One thing is you can put a CTR. If it's a small amount of luxation, so you can put a CTR and you can have a well-centered lens and you can go ahead and do the rexus and all the surgery. The other could be using iris hooks on the table. So this will depend on the type of cataract. So the harder the cataract, the more the hooks. So what are the concept of the hooks? I'll just tell you one. Don't use old hooks. It should not be like a V, it should be used. The hooks should be used so that you can actually hold it well and the capsule actually comes at the edge of the U, not at the end of the V, other it might cut through. Okay, so this is one video. So this is a soft cataract. You can see the luxation is pretty good. It's in fact more than 180 off. So you do a rexus, and rexus is always a little tricky in these ones. You use a higher viscoelastic, higher molecular weight. Anything 4 million Dalton should be good enough for you. And once you do a rexus, you need to have it with the forceps only. I mean, you can't finish this with a cystitome, it will run off. And try to ensure that you center on the lens, not at the eye, because otherwise you'll have offside. It will be a little not in the center. So once that is done, then the trick is to put the iris hooks. When you put the iris hooks, you have to ensure that the iris hooks actually go almost at the limbus, posterior limbus. And once you put in the iris hooks inside, you ensure that they don't get tucked into the lid. It should go over the lids. So if it's going into the lid, you please open the speculum a little bit. Otherwise, if it's inside the lid, when you move the eye, it might tear the capsule. So you have to be careful. And the second thing is you have to remove the parallax. Now you see there are two edges of the lens of the hook. You can see anterior and posterior. Whereas by the end of this, you should be able to move. Now see, you can see one only. That means they're all in straight line and they're not torting and not rotating during the procedure. So that's how you should use it. And then after aspiration, you can go ahead and put an implant. And how do you put the sclerofixation? I'll come to that in another video. Okay. Now this is one in which is a hard cataract. So harder the cataract, more the number of forceps. So sorry, the hooks. So you've got 4 iris hooks here, and this cataract can be easily managed. And this one, I think I use about a 25-30. CD is about 2014, it's going to about 20, and the surgery was done. And you see how well you can do it with the support of 4. And if it's more subluxation, you can put higher number of hooks also. Okay. Then comes the most important thing, like just putting a CTR is not an answer. You have to put it to the sclera. You have to put a good suture to that sclera so that it can stay. So where the sione comes. So I think I'll come to the video straight away. Now, if I take this needle, I put it from outside, I can ensure that I come 2.5 from the limbus. If I take my needle from inside and want to come out, I can never be at 2.5. It can go anywhere and it can damage the silly body also. So it's always better to have the needle coming from the outside, the cystitome, and the protein needle, long needle coming from the opposite side. So I'll just show you in this video. So before opening up the conjunctiva, you actually mark the area where you get the maximum, you've got the maximum dilatation, maximum subluxation rather. Now you made a scleral flap. You have to have a 50% scleral flap. It's best to have a proper blade to do that, and there's an opening on the opposite side. Now my rexus, if you see, I'll start initiating towards the broken zonule from the intact one. So I go from this side, I push it downwards, where the maximum subluxation are noted. And you can see the stretch zonules there in this patient. And once your rexus is done, again, I repeat, because the rexus in these one has to be done by the forceps. You can use a long forceps intravitreal, or you can use a utrata. In this case, I'm using utrata, ensuring that you center it onto the lens and not onto the cornea, because the lens is already off the center. And once you fix it up, your rexus will not be in the center. Okay, so once you've done this one, you do a gentle hydrodissection, and you're lucky in this patient because it actually, the capsule released the lens in toto. So I could take the nucleus out and it just came into the anterior chamber, and wow, I just was behaving like Kaufman. I mean, how it started was all in the anterior segment. So this was actually done in the anterior segment with the aid of a viscodispersive. In this case, we use OVD, which was a viscoat in this case. And once this cataract is done, you have to be gentle. You can keep putting in viscoat again and again, ensuring that you don't damage the endothelium. And once this is done, then you have to do a bimanual aspiration. Bimanual because you don't want the infusion and the aspiration coming from the same handpiece. So by using 2 hands, you can actually support the bag with 1 hand and keep aspirating with the other. I'm going faster because my time is less, so I won't be able to finish off in that time. So once I come with bimanual,
no issues. You can take time, Coco. No issues.
Oh, perfect.
Yeah.
Thank you. So I'll change the gear. So now the important thing here is to put the needle through the sione. Now this is a sione I'm putting, and you see my needle, the cystitome is coming from outside at 2.5 millimeter away, and it can come very well because you've got a very good firm eye, and you can come. If you use the other thin needle to come out from the other end, it's not possible. It's not going to happen because it will be, you won't have a control on that. There won't be a fulcrum there. So one is gone. Then you ensure that the suture is passed from the knuckle, and I'm putting the second one. Now, the important thing here is to ensure that you don't catch the tissue at the cornea. If you catch the tissue of the cornea with a needle, you have to cut it. Otherwise, this sione is not going to go in. Trick here is to put the sione under the sutures. You can blindly go under the suture with the leading edge of the sione. It will never get entangled. Ensure that you don't go over it. You go under the sutures, and once it's into the bag, then you can just pull it. The second trick is here that you can enlarge the section a little bit so the knuckle doesn't get stuck. I've seen some people struggling with the 2.2 incision and the knuckle gets stuck and the knuckle breaks off. So you can go to 2.8 in this patient because as such, so many things are compromised. Increasing section by a 0.4 is not going to make a difference. So once you tie it up, then you can actually see the bag. So you put a 3 throw, you put 1 throw and then 1 throw, and always leave a little longer arm when you cut it so that even if it expands a little bit later, it doesn't open up because this suture is going to stay with him for the lifetime. And in fact, when you discharge the patient, please write it on the cards that do not cut this suture even if it gets exposed because it can cause problem. That's why we've taken a scleral flap in most of the patients. I don't believe in Hoffman pocket much because if I want to go 2.5, my corneal limbal Hoffman pocket might not be as good to control the tightening of my suture. So that's why I switched over to the flap, which works wonderfully well at our place. So I got 3 knots and 1 for the safety, and then we cut it off. And you see how well the bag has been centered. And once the sutures are cut and the lens is in the center, you can put an implant now. And whichever you have, you can. The only thing is the knuckle has to go over the margin. So the knuckle will not, the anterior axis will not be actually attached, touching certain areas to the IOL because the IOL will be posterior and this will be pulled anterior. So that's why there's a little higher chances of VO formation in these patients. That's what you have to be a little careful, and the patient might need a YAG later on. And once this is done, you do bimanual aspiration. And then you always constrict the pupil on the table and you see if there's no vitreous. Now, this was the area of subluxation and the pupil has come all around. That means there's no vitreous there. And in case you have a vitreous tag coming there, you can always do a vitrectomy, local vitrectomy in that area and get away with that. Okay. So this was the post-op 1 year. You see this patient has started developing VO in the periphery, and you can see the knuckle here. Whereas the other patient, we were very happy to put without any, 3-piece lens was put and see what has happened. This is going to get crumpled more and get fibrosed. And this lens entire has to be taken out, and you can't actually fix this back onto the position. So that's why it's always better to put a sione. If you can't put a sione, please put a CTR in this patient in the beginning. Okay, so we did another study in which we did a sequential and a simultaneously, meaning that we did both the fixation of the sione as well as a CTS at the same time. And another group, we did it after 4 weeks to 6 weeks. And we realized that this is one set and there's a second set of patients. And we realized that the one in which we're doing simultaneous, which is on the right-hand side, left-hand side for me, was better than the other one. So see, the centration was not as good in this one. This was better. The lower one is much better. Okay. Now, the mother of all subluxation is a spherophakia. Now, see, this lens is an anterior. It's not cataractus, but you can't leave it alone. Otherwise, it will eat up your endothelium. So you have to take it out. So what you need to do in this one is we did a study in which a spherophakic patient, it's a prospective intervention study published in Eye. We realized that these patients have to be handled. This is one of the patients in which we operated 2005, and we're very happy about it that we have fixed in the lens. But after 5 years, the patient came back. We just put a CTR there in that one. The patient came back with the CTR bag lens complex into the vitreous, which has to be taken out. So this is one of the light surgery which was performed at Westmead Hospital, in which I was given this case to do, and this was spherophakia. After doing the hydration, I realized that I was able to manage it with the bimanuals, and then only I created my scleral flap. Before that, I put a Morse's ring. I was not sure whether I'll be able to do it. Once I got, see how small the bag is, because the Morse ring is getting so much of overlap on it. It's more than a 5 millimeter overlap. That means it's a very small bag in this condition. So after that, we created a scleral flap. And now, after the scleral flap, now I started creating, but most of the patient, you should do it first, do it before. Here, I was 100% sure I won't be able to manage it. So, but once I got in, so we did it later on. It doesn't make much difference though. Now, after that, I use a CTS, which we don't get very easily here. A good quality CTS. This was AIIMS CTS, which I think costs for 8,500. Now, see, the CTS is like a hanger. So you either putting a coat on a hanger, you can actually take this and go inside and put it in the bag. And CTS alone will not work here. You have to have either a CTR or a Morse's ring before. And once I put in, you see, it's so easy to handle this one because it's very small segment, and it's a very easy to maneuver, and it can be easily pushed at the place. I'll go a little forward there so you guys can see. Now see, it's gone there, and I just put in and pull it and tighten it. And after that, of course, I'm going to constrict the pupil. And these people at that Sydney hospital had done so many PIs when still they were not able to manage this glaucoma in this patient. So this was published subsequently. Now, so we also developed a technique in which we do interlenticular aspiration for these lenses which come anterior, which was published in Eye again. And you see that I go with a stab all the way into the lens. This lens is actually sitting into the anterior chamber and touching almost all the entire cornea. So if you don't take it out, it's going to eat up the endothelium, and we'll have to refer it to Dr. Namrata or Dr. Tityal for a DSEC or something. So once this is gone, I thought, let me peel off the capsule bag and see how it feels. So I just held this bag, which was empty, and I could make out, and you can see the oozing from the iris surface wherever it was stuck. And this looks like a good FAK at this. So after that, you can plan whatever you want to do for the rehabilitation of this patient. And these are the set of rehabilitation you can do. You can do AC lens, which is we're not doing anymore now. You can do iris claw. And if you have time, I can show you the iris claw fixation. Otherwise, I think my talk is over. Yeah, thank you.
Okay, good. Yeah, Namrata.
Thank you so much, sir. Again, I think very tough situations, not everybody can do and handle. And you handle so elegantly and effortlessly. Everything looks effortless in your hands. Thank you so much. Are there any comments or questions by any of the panelists? Rajesh, would you want to comment? Since
In a grossly subluxated cataracts, what will be your preference? Segments with CTR or a single or double eyelid CONE?
Yeah, I think, Rajesh, the double eyelid CONE is a myth. Nobody should use it because too many holes, too many sutures, all entangled with needles all around, it doesn't work. So my take is put a CONE and put a segment on the opposite side. That works the best because once you fix the one end and you've sutured it up, and you do the second one, or you can leave the sutures a little loose. And sutures are already extraocular. They come out from the sclera, you can manage it. You put a loose knot and then put a segment on the opposite side, and then you can titrate and tighten up. I don't believe in double CONE at all. And if it's too much a luxation, getting a rhexis itself is impossible. So in my cases, if the luxation is high, very high, in which you are, in those ones I do, if it's a soft cataract, I do a lensectomy, I get away with I get a good aphakia. I think a good aphakia is as good as having a good pseudophakia. So if it's a bilateral case of say Marfan's or a Beal syndrome in which the sclera is thinned out, and you don't want to put any SFILs or any other thing to the iris, bilateral aphakic glasses in these patients work wonderfully well. And that in other scenario, if it's a high myopic eye with a subluxation and the power is coming to say a -1 to a +2, in those ones also aphakia can work wonderfully well rather than sticking anything to the iris. But yes, well, after said that, I think I still feel that I can put iris claw retro, which we're doing now. But managing a lens itself is the most important technique, and that's what I tried. What I'm trying to show. So if you can have a trampoline, if you can create a trampoline, you can save the bag. If you can't create a trampoline, it's best to eat up the entire thing rather than leaving any mark inside.
Yeah, so Darshan, just one query. Like,
please.
People would use, instead of iris hooks for capsular bag fixation, they use, capsular retraction hooks. What is your comment on that? Is it necessary to use those bulky, hooks?
You answered it yourself. Okay. So what I feel is that capsular hooks are meant for, I think, Western capsules, because our capsules are not that big. We did a study on the UBMs. We realized that the congenital cataract, when we do, even in the age of 6, 7, 8 years, the size is never more than 8, 8.5. So if you have longer hooks, they can actually rupture at the equator. So I don't recommend, I don't use those ones. Either you use them with cutting. If you use fresh iris hooks and Grishabas, if you can buy, which is a little expensive. I didn't want to touch on anything expensive here because I was taking a basic talk. So you can use this Venu iris hooks easily, new ones without any problem. And I agree with Professor Tityal that those big, bulky, long handle things are of no use to us.
Yeah, sometimes they make situation more complicated than helping,
I know.
Other thing, Sudarshan, people are here. We have access to a femtosecond laser also.
Yeah,
have people tried femtosecond laser in a subluxation cataract?
Yeah, I think that's a good idea. So when I show the soft cataract thing in which I was doing the rhexis, which is going a little off, in those ones, if the centration is there and your pupil is loud, you can actually do a good rhexis with the femto and get away with that. And I think lots of videos I've seen and people have done it. I've done it in few patients, works well. But I have realized that most of these patients who are coming to us with subluxation, somehow they belong to a poor socioeconomic status. So they can't even afford that doc of 20, 21,000, whatever. But yes, if you talk otherwise, yes, of course, if it's a patient who can afford, yes, I would love to do a femto and get away with the rexis complication which you can have, and you can get away with that.
Okay, thank you. Thank you.
There is a question, the reason for making a scleral flap later in the spherophakia case. In the spherophakia case that you showed, so Dr. Sai wants to ask why the scleral flap would you make it later?
Later. In that was, I just mentioned also, because this was, I think, first case in the morning in Sydney, and I think my jet lag was not over. And they told me this patient, I saw the patient, I said, no, well, I don't think I'll be able to manage it. So the other guy has done, Neil had done the other eye, and he had put a SFIOL in that one. He did a lensectomy. So I said, let me try and let me go step by step. So I did a rexis, it happened. I did the aspiration, it happened, and the Morshers went in. Then I realized, okay, no, I think 80% the thing is over, and then made the scleral flap. But yes, in my condition now in an RP center, I always make a flap first, and it's always better to dilate it. First, enter the chamber, put a little adrenaline, you can put a phenocaine, pupil dilates. You can assess the luxation. Where is the maximum luxation? You just put a mark on the conjunctiva and then create a conjunctival flap around it. And scleral flap is what I prefer rather than a Hoffman pocket, because Hoffman pocket, you go from the cornea backwards and you try to suture, take out the suture. You can never titrate it as well. So I put a flap, but my flap is about 50% thickness. So I never had an extrusion till now. I think that's why in this case—
What about the groove, sir?
Sorry?
What about the groove?
No, I can't hear you. What
Groove,
about
Scleral grooves. Groove.
groove, scleral groove?
Groove, yeah.
I didn't get your question, Rajesh.
Sir, instead of flap, if you can make a groove and slip the knot inside the groove and leave a slightly bigger.
Okay. See, Rajesh, once you have tightened the knot to the desired strength, which I don't tighten too much because I don't want the zunule from the opposite side peeking out. So when you rotate the knot after that, it normally actually gets too tight, and the knot of yours will go and get stuck into the knuckle. So it becomes a little— I've tried in one case to rotate, then I stopped rotating these ones. I don't rotate the knot now because these knots per se can cause issue. Rotation of the knot can tighten the sione more.
Okay. I think there's one more question. Which suture you prefer?
Okay. This one is it's a non-absorbable suture. It has to be a Prolene, which is non-absorbable. I mean, there's no other way. The one which you're using for conjunctiva, you can use anything. For the scleral suturing, you have to have a non-absorbable suture. Period.
No, you're doing 90 or Prolene or something like people
90
are
and
using
10-0
Cortex, you know.
Yeah, that's right. 90 or 10-0 is what you should use, not 11-0, 11-0. And in fact, there's a study by Buckle and al., in which they found that all these SFIOLs and all, after 5 to 6 years, 40% of them actually got disengaged because they opened up, although they were non-biodegradable. The suture they used was 11-0 and 10-0. So that's why they say you should use 9-0, which has got 120% more tensile strength. And if you cut it across, it's got 140% more surface area when you cut it. So I think 9-0 is what should be used in these patients.
Okay. Yeah. Thank you.
Thank you very much.
Yes.
I got to leave because I have some function. Thank you, Dr. Tejal, for having me, and Dr. Namrata and everybody. Thank you very much. Bye.
Manpreet, you can call the next speaker.
I now invite Professor Namrata Sharma to present her talk on phacoemulsification in compromised cornea. Ma'am, of course, needs no introduction at all, and she has done extensive work in a host of corneal pathologies and phacoemulsification in them. Over to you, ma'am.
Thank you, Manpreet. I would be talking to you about phacoemulsification in compromised corneas, one of my favorite topics because it combines both the cornea and the cataract. There are no financial or proprietary interests, and I would be discussing to you about the off-label use of trypan blue dye in the air. And of course, herein I would be talking to you only about how cataract surgery should be done in the presence of corneal haze and not about the corneal transplantation procedures. Just suffice it to say, but that if the compromise or the opacity is in the central part, you do a corneal transplantation, but if it is in the peripheral or paracentral part, you do a cataract surgery. Always there is a question on what type of intraocular lens you should use. So one should use monofocal lens for keratometry. One can do a peripheral video keratography or use a standard keratometry. IOL master is often not possible, and biometry can be done by ultrasonic B scan. Now, we have published this algorithm for cataract surgery in the presence of corneal opacities in Journal of Cataract and Refractive Surgery. And whenever there is suboptimal endothelium and cataract management, then I think the key is the visualization. If the visualization is poor, corneal thickness is more than 650, cells are less than 800, then one cannot do cataract surgery alone, have to combine it. But if it is less than 650, cells are less than 800 cells, then one can do sequential procedures and see how it goes. The incision has to be planned because at least one half of the cornea should be clear for you to do the phacoemulsification. So for instance, because the opacity is on this side, the temporal incision is planned because all the procedures can be done from this half. As you go underneath that opacity, you have to go in one go because you can't lose the edge of the rexis there. Do very copious hydro procedure, hydro dissection, hydro delineation, because that causes the disassembly of the nucleus and helps you to do your nuclear emulsification in a more efficient manner. And of course, irrigation aspiration in this case with the coaxial is being done, but you may have to use a bimanual irrigation aspiration also, because at times it becomes difficult to find those cortical, to find the cortex which is camouflaging underneath the opacity. Now, this could be a classical case where a corneal opacity healed keratitis is there with in a one-eyed patient who doesn't want a corneal transplantation in a hard cataract. And again, the rexis is being done with the help of the Atrata forceps, and even the globe manipulation is being done because you can't see the edge of the rexis there. Because in this case, the optical iridectomy is there, so eccentric rexis and eccentric crater is being made here. Always keep your operating microscope in retroillumination, because as you chop, emulsify, and the orange glow gets better and better, and the nuclear fragments which are grayish or brownish are seen better against a red glow. So it is important and imperative that the red glow comes sooner than later. And these little fragments can get camouflaged again underneath this opacity, which have to be lollipopped into your phaco probe or the irrigation aspiration probe, followed by a foldable intraocular lens implantation, such as here. Again, in this case, nylon hooks were being used. This case, in fact, was not planned for cataract surgery. Case was only planned for pupilloplasty, but here the pupil was enlarged and cataract was seen underneath. So again, the cataract surgery as such was not very difficult to do because this was a soft cataract, and irrigation aspiration was done again using a bimanual technique, followed by the foldable intraocular lens implantation. Now, this was a small pupil with the hard cataract again, so you have to expand your area of visualization by putting the nylon hooks. And again, the incision is temporal, using this half as the clear area from wherein the procedure emulsification can be performed, was shown earlier. Now here again, this was a case of whitish opacity with the tattooed cornea, and synechiae which were present, which have been released first. Again, because the pupil is small, the area of visualization is expanded. And sometimes when you do lose the edge of the rexis underneath that opacity, you can actually pick it up by globe manipulation and looking at the edge of the rexis on the intraop OCT microscope if you have it. But the principles again remain the same. The retroillumination to be on, phacoemulsification, nuclear emulsification is being done, followed by irrigation aspiration and intraocular lens implantation. Once you implant the intraocular lens, everything gets a little more brighter and clearer because this neutralizes the aphakic refractive error. And one can then remove the nylon hooks and do what I call the pilocarpine test, in the sense that you can even do pupilloplasty because you want to see, because the patient has to see post-operatively, and you can put then inject air bubble and put pilocarpine to see how much the pupil will constrict, and to see that there is some area which is beyond this opacity and which is clear, because from that area the patient is going to see in the post-op period. So this is a good test, and you would know that in the post-op period, the pupil, how much area would remain uncovered by the opacity. Now, this is again a case of leukomatous corneal opacity, again because of field keratitis, which is paracentral. Incision is planned temporally. And in this case, toric intraocular lens was planned because the astigmatism was not very irregular. And this was an opacity which was fairly localized. Now, in this case, this is just to highlight the fact that if you do lose the edge of the rexus down there, then it becomes difficult. But because of the double fold of the capsulorhexis, one can see and can again pick this rexus up from underneath that opacity. And then, like I said earlier, hydrodelineation and hydrodissection is very important because that causes the disassembly of the cortex, of the nucleus, as well as of the cortical matter. I've seen Dr. Tityal sir doing hydrodelineation number of times, even when he does normal cataract. And I think that is the key to success because that softens and causes the disassembly of the nuclear fragments as well as of the cortical matter. And after doing this, the irrigation aspiration, one can then do a toric intraocular lens implantation, as was done in this case from Zeiss, because this was a high cylinder, and the patient did have a good visual acuity, which was unaided 6/12 in the post-operative period. Now, of course, in these cases also, just to highlight the fact that sometimes you have to use multiple techniques like this endo-illuminator to cause chopping of the nuclear fragments to see where actually the chopping is happening, and sometimes the endo-illuminator, which is outside, to see where the intraocular lens would go. Again, the nylon hooks have been used, and again, the temporal incision, so that this half of the cornea is clear to do your surgery. The aids are very important in these cases. These are the post-operative results of some cases in corneal haze, although the visual acuity is not 6/6, but then it allows the patient to be ambulatory. And it is important that when you're doing phacoemulsification in these cases, your parameters have to be low. Even in the cases of corneal haze, femtosecond laser really helps, because when you do make a capsulorhexis, like in this case, there could be skip areas or underneath the opacity where it is not going to, where the rhexis is not going to be complete. But because the laser has already made it, it is easy to fill in the blanks. So you can see underneath that haze and just make the capsulorhexis, which is complete. Again, this is a second case of haze in which the capsulorhexis is being done, and then there is a gap area which is present right here. The capsulorhexis is not complete here, but then it is easy to just take the edge of the rhexis and see that this gets completed because it has already been done by the laser. So there is less amount of stress on the capsule itself because it is already cut by the laser itself. And of course, the other parts or the other steps can also be done using essentially following the principles that had been discussed earlier. So to conclude, it is to use aids like nylon hooks, optical iridectomy, trypan blue dye, dispersive OVD and BSS plus again, so that the endothelium is not compromised, eccentric crater, eccentric rhexis in some of the selected cases, low fluidic parameters, and counseling of the patient is very important because you may not achieve 6/6 in all of these cases. Thank you very much for your attention.
Yeah, thank you, Namrata, for a beautiful presentation and classical videos where many of us may not be able to see or how to do phaco in those cases. I think well done phaco in these compromised situations, as you described. One eye patients or where keratoplasty is not a preferred because of various reasons. we have seen that patient do gain good vision, and they can survive for a very, very long time. And I see Dr. Bharti there. Welcome, sir, for joining us today. Achha, he's muted. So I think apart from that, I think query would be, opacity, yes. What about those cases of Fuchs endothelial dystrophy, where I'm pretty sure, femtosecond laser will be advantageous? And what is the, your you can experience in these cases, femto versus routine phacoemulsification?
And I think completely agree on that, that if you do use femtosecond laser to make rexes for cases of fixed dystrophy and also to make chops, then the energy levels which are going to be there by the ultrasonic machine are going to, the requirement for that would be much less. And so as a result of which the endothelium damage is going to be much less, which is what you want in these cases. So I think it would be good idea to go in or err for femtosecond laser rather than conventional phacoemulsification techniques for these cases.
I think you talked, you really told us what are the accessories required for these, corneal haze or corneal opacity patients. I've seen many people use, pars plana illumination. So how does that, would that be beneficial in these cases?
Sir, it really helps a lot. That is one video which in fact I didn't show, but because of the chandelier illumination which happens through the pars plana route, you can actually see your haze is nullified completely. And the cataract surgery can be done. It is a different experience. There is a little learning curve to it, especially for anterior segment surgeons, because it doesn't look the same way as it does when you are using a endo illuminator from outside.
Yeah,
so that learning curve is definitely there, but as one goes by, one learns how to do it, and it is much easier to do with a chandelier illumination rather than do with the endo illuminator.
Okay, thank you. Dr. Bharti, sir, any comments?
Good evening, Dr. Tel. In all these and good evening all these cases, I definitely agree with Dr. Namrata that if you have a femto, it helps you a lot in achieving whatever you want to do in a very perfect manner. So I think there's no doubt about that. And of course, if you have an opportunity to doing the keratoplasty along with the cataract surgery in all these cases, it's a better option, but sometimes the patients do not agree, like in a few cases which he showed. But I would prefer plasty along with cataract surgery.
Triple procedure.
Triple procedure.
Okay. Yeah, Dr. Rajesh, you're saying something?
Yeah, actually what I felt, sir, that with chandelier, it is very useful in cases of haze.
Okay. Yeah, but I've seen, I'm stuck, or who is stuck?
No, Dr. Rajesh is stuck, sir. I think his internet connection is slow.
It's helpful in both, haze and opacity. I've seen the beautiful pictures, videos from, Dr. Mahipal and others.
Very nice.
Would you recommend that vitrectomy?
Glow. And if it's a...
No, I have asked this question, what Parful is asking, to these people, because it's a formed vitreous most of the time, but these are used for all type of cases. These are non-vitrectomized eyes, but they say it does not cause any significant post-op problems.
It can be used in non-vitrectomized eyes, that's not.
Yeah. One question before we go out of this session, Dr. Namrata, because most of these cases would have, we'll cover that topic subsequently, but just to complete, the post-op period, because cornea is compromised in these cases, ocular surface wise. So would there be any change in a post-op protocol?
So post-operatively, I think they would have corneal edema more than your normal cases. So to begin with, we would give frequent topical steroids, topical antibiotics. You may have to give sodium chloride for these cases, 4% eye drops and 5% ointment. And if I'm doing a Fuchs dystrophy, then I would also like to give something like a Ripotec or Rho kinase inhibitors, because you would want the endothelial cells pumping.
Okay. Yeah, Dr. Manpreet, next.
Yes,
So
sir.
it is my pleasure to invite the next speaker, who's Dr. Manpreet Kaur, who would be talking about optimizing outcomes in toric intraocular lenses. Dr. Manpreet Kaur is working as assistant professor in cornea, cataract, and refractive surgery services, and is very bright, dynamic, and intelligent. And I'm sure it's going to be a treat to hear to your talk, Manpreet.
Thank you, ma'am. So I'll be talking about optimizing outcomes in toric intraocular lenses. So this is a review article published in Indian Journal of Ophthalmology that comprehensively covers the preoperative, intraoperative, and postoperative points that you should look into to optimize the outcomes with toric intraocular lenses. So we all know that anything above 1 diopter or more nowadays, we do go for toric IOLs. And in fact, when we are implanting multifocal toric IOLs, you should keep a lower threshold of around 0.75 diopter of fill to implant a multifocal toric rather than a multifocal alone. Preoperatively, IL par and axis have to be taken into account, and ocular surface examination take into account the angle alpha and higher order aberrations if the lens is contributing to the aberrations or the corneal surface. Intraoperatively, precise toric IL alignment has to be ensured, and then there may be challenging case scenarios such as a rupture or a small pupil, wherein it may be more challenging to implant a toric intraocular lens. Postoperatively, any misalignment has to be tackled and surface issues have to be addressed. Patient selection, of course, is of paramount importance, and you have to know when not to implant toric IOLs. Corneal scars, irregular astigmatism, poor ocular surface, prior ocular surgeries, vitreoretinal procedures, poor pupillary dilation, posterior capsular dehiscence, and zonal instability may be relative contraindications. And then corneal curvature and IL par have to be ascertained preoperatively. Angle alpha has to be looked into because the IL tends to center on the limbal center and not over the visual axis. And anything angle alpha above 0.5 mm combined with a multifocal or toric gives compromised vision. Corneal internal and total higher order aberrations must be assessed, because when excessive higher order corneal aberrations are present, premium vision will not be attained with the premium lens, and high patient expectations are typically present in cases which are more premium. So you will have a dissatisfied patient at your hand. Biometry, optical methods are preferred nowadays whenever feasible. Keratometry, it's important not only to determine the par and axis, but also to use at least 2 different instruments and take multiple measurements to enhance the accuracy and ensure repeatability. So cases in which you have similar steep corneal meridian on different devices are good candidates for toric IL implantation. When you're getting variable axis and magnitude of toric IL on different devices, rule out coexisting comorbidities, and the visual outcomes may not be that satisfactory in these cases. Posterior corneal astigmatism is something that all of us are talking about in the recent years. Anterior corneal curvature is what we have already always taken into account with our conventional placido disc-based keratometers, which shifts with age from with the rule to against the rule. Now, the posterior corneal curvature also has some toricity, which acts as a minus lens, causes against the rule astigmatism, generally stable with time. And if you do not take it into account, you end up with overcorrection of with the rule astigmatism and undercorrection of against the rule astigmatism. So almost all the newer optical devices that we use for estimation of keratometry and IL par calculation do take into account posterior corneal curvature in one or the other form. AIIMS 700 uses a swept source OCT, then LensStar incorporates a Barrett formula, and so on. So any of the newer generation devices and newer generation formula work well enough. Ideal IL par calculation, of course, will give you magnitude of IL par, toricity, and axis. Take into account the surgically induced astigmatism, posterior corneal curvature, and the effective lens position. Baylor nomogram, Barrett toric calculator, online calculators, almost all of them incorporate the posterior corneal curvature or correct for it. So any of these newer generation formulae, as said earlier, work well. Now, just to highlight a case of a patient plan for a multifocal IOL in which conventional corneal astigmatism was 0.74 diopter, taking into account only the anterior corneal curvature, and you would have gone for a multifocal alone in this case. But when you take into account the posterior corneal curvature as well, the true keratometry as given by the Barrett True K, It's a 0.89 diopter of a cylinder, and a multifocal toric IOL will give you better, more precise visual outcomes in these cases. So this is just to highlight the significance of posterior corneal curvature. Now coming to intraoperative alignment, you can go for either manual marking methods. The conventional 3-step marking method has been described using slit lamp, bubble marker, pendulum marker, tono markers. There are a lot of markers available. Then image-guided surgery for precise intraop alignment. We have Callisto Ion, Z-Align, and Varion. Ray tracing aberrometry using eye trace has also been used. It has a tool called Zaldivar calipers. Then intraoperative aberrometry helps you make real-time decisions regarding the IOL power and axis and when and where to rotate. And OptiWave refractive analysis, or ORA, gives you a static aberrometry, and HOLOS, which is still not commercially being used, gives you a dynamic aberrometry. So we compared toric intraocular alignment and visual quality with image-guided surgery and conventional 3-step manual marking, and observed that even though the visual outcomes are similar, the quality is much superior with image-guided surgery because the alignment was much more precise with a significant p-value using Callisto Ion Z-Align, in which an overlay is projected wherein you can align the toric IOL. So these are the modulation transfer function and point spread function comparisons between the two methods, with superior outcomes with image-guided surgery and a negative correlation between deviation from target axis and visual quality. So this is just a brief video highlighting a manual method of marking, because commonly a lot of us across the country will be using this. So these are the reference marks placed preoperatively. Then a Mendes ring is used to align to the reference mark, and then axis marker is used to mark the target axis, which is 85 degree in this case. And then the intraocular lens is put and aligned to the target axis. You leave it slightly anti-clockwise, and the final alignment with the reference marks is done during wound hydration, because the lens will rotate only clockwise. If you overshoot, then you will have to go again 180 degree to align the IOL mark with the target axis. A well-centered capsulotomy, of course, is a prerequisite to achieve optimal outcomes in any premium IOL, and in fact, even with monofocals. Then femtosecond laser-assisted refractive capsulorhexis allows precise capsulotomy with accurate toric IOL alignment. In fact, one of the laser platforms gives you a refractive capsulorhexis, wherein a notch is created in the capsulotomy during laser application, and you can align the intraocular lens along this notch. So you can make the notch along the target axis, and as you can see, it gives you such precise outcomes. Even in the post-op, you can see this notch over here, and the toric IOL is aligned, that no rotation is required as per the ray tracing aberrometer. Is so precise. Post-operatively, you have to assess the toric IOL alignment, and various methods are present, including slit lamp-based assessment using a rotating slit and rotational gauze, ray tracing aberrometry, which has a toric IOL enhancement software, retroillumination photographs. You have smartphone apps. astigmaticfix.com is an online software, and misalignment can be due to a host of causes preoperatively due to inaccurate IOL power, wrong axis calculation, then an inaccurate alignment or placement of a wrong IOL intraoperatively, and post-operative rotation. So iTrace toric enhancement software gives you how much of rotation is required and what would be the post-op predicted refraction. So in this case, it tells you to rotate 26 degrees so that there will be a 1.56 diopter change in cylinder power. And after, so it gives you both the direction and magnitude of rotation relative to the current toric IOL position. Realignment is required in cases with more than 10 degree of rotation and visual acuity worse than 6/9. And it's more with thickness and silicone lenses. In fact, the axis of toric that we usually implant is very stable. Repositioning can be performed after 1 week of primary cataract surgery, and it has superior outcomes in terms of precision of IOL alignment and minimal residual refractive cylinder. If you go in too early, the IOL may rotate again. If you go in too late, there is capsular bag fibrosis and increased risk of complications. So just to summarize, to optimize outcomes of toric IOLs, preoperatively do a comprehensive assessment and precise IOL power calculation using any of the new generation formula. Intraoperatively, precise alignment. Of course, the image-guided systems fare better than manual marking, less errors. Post-operatively, assess the IOL axis of implantation, assess residual refraction, and rotation may be required if the visual outcomes are suboptimal. Thank you for a patient hearing.
Thank you, Manpreet. Beautiful presentation and finishing well within that time also. I think it's a big topic, but you managed very precisely, and all the important points been well covered. You rightly pointed out, I think the biometry is very important for all premium IOLs, or even for a toric IOLs. The biometry should be the first investigation, so that you take the virgin cornea for assessing the corneal toricity, which is so important for these cases. And rightly pointed out, multifocal torics would require a more precise assessment and placement. And the manual way of marking reference and axis marking also works very effectively also. We have seen most of us have been using manual marking, but if you have access to a automated system, why not to use them? But definitely they'll improve the outcomes. I think most of the points have been well covered, and we can go to the next speaker, Dr. Manpreet.
Yes, sir. So it's my pleasure to welcome Dr. Sudhank Bharti, who will be covering newer paradigms in post-operative management of ocular surgery. Sir is founder and medical director of Bharti Eye Foundation and has extensive experience in cataract, cornea, and refractive surgeries. Over to you, sir.
Thanks for those kind words, Dr. Manpreet. And okay, here we are.
Okay, sir, you're on.
Okay, I thought my slides are not
No, it's visible.
visible. Perfect. So I'll be talking about, let me
You have to go to a
minimize
slideshow.
this.
Slideshow,
Yes.
sir.
Yeah, that's what I said. I was opening the slideshow, but it is somehow.
Okay. Then I think you can reshare it.
Okay.
You can close this and reshare the
Screen, entire screen.
You go to share screen, then click onto your presentation.
I have to go back for a while and then I'll start because I have to start from the, yeah. So just in a moment, I'll come back. I think you guys have to wait a little. Okay, here we are. Okay.
You can share the entire screen rather than
Instead
sharing
of
the
PPT.
PPT. Yes, sir, because I think you're using a Mac. So maybe having issue.
Yes, a shared desktop would work better, sir.
I think sometimes it's not I think
Okay.
it's hung, so I think I'll take the next talk. That'll be better.
Okay. That's okay.
So we'll move on to the next talk for now. We have Dr. Sridevi Nair, who will be covering post-operative management of unhappy patients. She's a newly joined assistant professor at RP Centre AIIMS. So let's hear it from her.
Thank you, Dr. Manpreet. I'll share my slide now. Yeah, so I believe my slide is visible. So
Yes. Okay, go on.
yes. So cataract surgery today is basically a refractive procedure, and despite a perfectly performed surgery, a lot of time you're faced with an unhappy patient. And the common causes of a post-operative dissatisfaction after cataract surgery is dry eye disease and residual refractive error. In addition to these, we have other phenomena such as the photic phenomena, which the patient may present with glare or halos, most commonly seen with multifocal IOLs, or even dysphotopsia, which is maybe seen with monofocal or multifocal IOLs. And patient may also have visual symptoms due to poor neuroadaptation of multifocal IOLs. And in addition to these, less commonly, you might see visual symptoms due to structural or anatomical issues, such as zonular dialysis, which leads to a decentered IOL, and any missed comorbidities, such as posterior segment pathologies, which may affect vision, such as epiretinal membrane, macular edema, vitreomacular traction, or even a corneal condition such as Fuchs endothelial corneal dystrophy. So coming on to dry eye disease and cataract surgery, which is the most common cause of patient dissatisfaction after cataract surgery. So cataract surgery can itself aggravate any pre-existing dry eye disease, or it can even lead to new onset dry eye disease. So studies have found that up to 80% of the patients who are presenting for cataract surgery may have either one sign or some symptom related to dry eye disease, and 50% of the asymptomatic patients have had an abnormal tear osmolarity or raised MMP9 levels. Preoperatively, an abnormal tear film can lead to a biometry error, which can affect your IL-PAR calculation accuracy. And postoperatively, a poor tear film can lead to induced aberrations, which can compromise your visual quality, increase the risk of infections, and slow down the healing and visual recovery. So much so that the American Academy of Ophthalmology and the ASCRS, they recommend routine screening for ocular surface diseases before refractive cataract surgery, even in the asymptomatic patients. And to be noted is that the degree of dissatisfaction with poor ocular surface is much more pronounced in cases undergoing a multifocal IOL implantation. So the basic pathomechanism for dry eye disease after cataract surgery includes the intraoperative ocular surface trauma, which can be when you're placing the speculums during your incisions, the phototoxicity due to the light, and any repeated irrigation over the epithelium, and even applying the suction during flax. Postoperative inflammation, abnormal meibomian gland function, and the toxicity due to postoperative medications are the other mechanisms that exacerbate the dry eye after surgery. Incidence of dry eye has been as high, reportedly to be as high as 80% at 3 months. And most of the patients clinically, they manifest with a reduced TBUT and an increased corneal staining as opposed to a reduced Schirmer in these cases. The patients may present with foreign body sensation, photosensitivity, glare, and halos, poor visual quality. And most cases, they resolve by 3 months, but may persist in up to 1/3 of the patients for up to 6 months after surgery. And the clinical approach is that even at the slightest suspicion of any dry eye in these patients, you should perform a thorough ocular surface evaluation, and just a simple step of staining the cornea with fluorescein dye can provide you a lot of information in these patients as to the nature of the dry eye. In addition to these, you can assess the tear meniscus height on an anterior segment OCT for objective tear secretion test. And the assessment of meibomian glands using a meibography or even lipid layer thickness with interferometry is very important, because meibomian gland dysfunction has been known to get exacerbated after a cataract surgery. In addition to this, you have some point of care tests such as the tear osmolarity or MMP9 levels, which may act as adjuncts if they're available with you. So various steps have been described to reduce the incidence of cataract surgery related dry eye. Preoperatively, it is most important to screen these patients, detect any pre-existing dry eye, and optimize the surface before planning surgery. Intraoperatively, you should limit the incisional damage. A judicious use of topical medications is recommended. Limit repeated irrigation and drying of the surface to reduce the epithelial trauma, as well as minimizing of phototoxicity. Post-operatively, however, the treatment is pretty much similar to what has been given by the TFOS DUCE 2 recommendation. It follows a step-ladder approach with some emphasis on control of inflammation using topical steroids, and even cyclosporin may be needed in cases with prolonged symptoms. So here we have a case example where a 55-year-old female patient, she presented to us 2 weeks following cataract surgery with a multifocal IOL implantation. Her uncorrected visual acuity was 6 parts and near vision was N8. She complained of glare and poor visual quality. So on a slit lamp examination, the IOL was well centered, but when we stained the cornea with fluorescein dye, we found this punctate patchy pattern of staining of the cornea, which pointed towards postoperative dry eye disease. And eye trace was performed, wherein we could see raised corneal higher order aberrations, as well as increased point spread function, which is suggestive of increased higher order aberrations in these cases with poor visual quality. The management included topical lubricants, preservative-free, nighttime ointment, and topical cyclosporin for 3 months. The patient reported a symptomatic improvement after 3 months of treatment, along with an improvement in the aberration profile, including the higher order aberration as well as the point spread function, which reduced. The next most important cause of postoperative dissatisfaction is a residual ametropia or astigmatism, and it accounts for about 29 to 57% of the cases who present with post-op dissatisfaction. So there are certain preoperative factors which may contribute to this, which include an inaccurate biometry as well as limitations of IOL-PAR calculation formulae in certain settings such as post-operative surgery cases. Intraoperatively, a variation in your rhexis size, surgical induced astigmatism, the placement of IOL in the bag instead of the sulcus, or vice versa, and also the in case of toric IOL, incorrect alignment and retained OVD, and an inverted IOL implantation intraoperatively can also lead to residual refractive error. Postoperatively, the posterior capsular fibrosis can lead to a contraction and an anterior IOL movement with an induced myopia. IOL decentration, IOL tilt, and rotation of the IOL in toric cases are the other causes of post-operative induced error. So it is important that to stay calm in such cases and counsel the patient well, and an accurate refraction can go a long way in these cases to find out how much is your error, and you should recheck and reperform all your calculations to figure out where you went wrong, and also to check whether the correct part of lens had gone into the eye or not. In addition, you should also look at the IOL position. So in certain cases, such as a posterior capsular block syndrome, the IOL may shift forwards, leading to a myopic shift. The management options in this may be conservative. In such a situation, may be conservative, wherein you use spectacles or contact lenses. Corneal-based procedures such as PRK, LASIK, or an arcuate keratotomy may be performed, preferably after waiting for 6 to 12 weeks for the cornea to stabilize. And lens-based procedures such as a piggyback IOL, IOL exchange may be also required. IOL rotation may be performed in cases of toric IOL misalignments. So just as a flowchart, so in cases of low to moderate refractive error, that is about less than 4 diopter, if the patient requires an immediate intervention, then you might need to go ahead with a piggyback IOL or an IOL exchange. If the patient can wait for 6 to 12 weeks, then a laser refractive procedure is a good option in these cases. And in cases of toric misalignment, you will need to realign the toric IOL as explained. So next we come on to the photic symptoms that are most commonly associated with multifocal IOLs, and of these we have glare, halos, and starburst, and they are basically due to the 2 foci in these 2 or 3 foci in these IOLs, and the out of focus images from one foci superimposed with the images from the other 2 foci, which leads to the phenomena of halos. And glare is usually due to the diffractive optics of these lenses. Dysphotopsia, the incidence is about 0.2 to 20%, and they may be seen with all sorts of lenses, most commonly with the square-edged hydrophobic lenses that we commonly use. And they may be positive or negative dysphotopsia, depending on the IOL design and the material, etc. So the incidence of photic phenomena after multifocal IOLs with the newer IOLs is actually quite low. And even from of these, the impact on the daily life of the patients or the clinically significant photic phenomena are even lower, maybe less than 10%, even with the IOL that has the highest incidence. So if you see here, the Panoptix trifocal IOL and the Synergy will show a greater photic phenomena as compared to an extended depth of focus IOL, and which will be more than the newer enhanced depth of focus monofocal IOLs. And the best IOL for photic phenomena are, of course, your regular monofocal IOLs. So the reason for these photic phanomena include the inherent IOL design, a decentered IOL due to an uneven capsulorhexis, a large angle alpha, any posterior capsular opacification, PC wrinkling, lens edge effect, a posterior segment pathology that was missed, and inadequate neuroadaptation in patients with multifocal IOL implantation. The clinical approach includes a detailed slit lamp examination to assess the IOL centration and the PC status, including any fibrosis or wrinkling. The pupil size should be assessed, especially if the patient has increased nighttime symptoms. The angle alpha assessment should be made, an aberrometry if possible, and the posterior segment evaluation using a macular OCT will help you detect any missed posterior segment pathologies. The management options may be conservative, wherein you can just observe the patient, because a lot of these phenomena, they are self-resolving and they may resolve in the next 6 to 12 months, especially as neuroadaptation improves. Or you can prescribe the patient with glasses or contact lens. Meiotic agents such as brimonidine are a good option for patients with positive dysphotopsia. In case of surgical options, patients with a PCO, which is visually significant, can be planned for a YAG capsulotomy, a piggyback IOL, an IOL exchange, or a sulcus placement, an anterior optic capture, and a YAG anterior capsulectomy are the other options, most of them for a negative dysphotopsia case. IOL exchange may be done in a positive dysphotopsia as well. So one thing that one needs to be careful with is that a PCO should be only performed, a YAG capsulotomy should be only performed if you are certain that the symptoms are due to the PCO and not due to the lens itself. Because once you perform a YAG cap, then a future IOL exchange can be quite technically challenging. So this is another case example where a 32-year-old pseudophakic patient presented to us with the complaints of blurred vision, glare, and halos, which were more during driving at night. The patient had undergone a multifocal IOL implantation 4 months ago elsewhere. His uncorrected vision was 6.9 distance, and with a 0.75 diopter sphere acceptance, it improved to 6.6. So as you can see, the IOL is slightly decentered temporally, and also the optic edge is not covered by the rhexis margin nasally. And we can see a significant PCO, but it is encroaching about the central 3 mm zone, but the visual axis as such is as of now clear. So on eye trace, we saw that the patient had significantly raised internal aberrations as well as decreased modulation transfer function, raised point spreads function, and also the optotype can show a very blurred optotype on the eye trace. So the treatment options include a conservative management or a YAG capsulotomy or an IOL exchange. What we preferred was that we started the patient on conservative management with topical brimonidine 0.15%, and the symptoms showed a significant improvement after 3 months of treatment. The patient is still continuing with that, and he's quite happy. So the message in this is that in these cases, conservative management should be given the due weightage, because a lot of patients, they either improve with neuroadaptation or even pupillary meiosis can produce a significant improvement. So to summarize, the most important way of tackling a postoperative unhappy patient is to not create one, for which a meticulous preoperative workup goes a long way. So you should detect and treat any pre-existing dry eye disease. Accurate biometry and ILPAR calculation will help you hit the target, and be aggressive in astigmatism control in cases of multifocal IOLs. And of course, when you're planning a multifocal IOL, a proper case selection and patient counseling is of paramount importance. Intraoperatively, a good surgical technique which minimizes the ocular surface trauma, creates a well-centered rhexis, and a proper removal of your cortical matter and OVD will help reduce the post-op dissatisfaction. And post-operatively, you should aggressively control the inflammation, especially in cases with pre-existing dry eye or those who are at risk for developing dry eye disease, and also manage them with topical lubricants which are preservative-free. Maybe start topical cyclosporin for around 3 to 6 months so that they are on good maintenance therapy. And in cases of residual refractive error, a good refraction, a good slit lamp examination to look at IOL centration, and aberrometry, if available, goes a long way in handling a large section of these patients. So I'd like to acknowledge my teachers and my seniors, Professor Titial sir and Dr. Manpreet Kaur, and thank you for your patient listening.
Thank you, Dr. Sridevi. A beautiful presentation. I think the summary was, covered almost every important point in a post-op patients. I think what we have learned today from your presentation is, conservative management is a good option for these patients. And to make everything effective in a conservative management, you have to have effective counseling for these patients pre and post-op. Otherwise, the conservative management is very difficult to satisfy patients. The counseling becomes a very important aspect of post-op unhappy patients, which we always talk. If you give more chair time to your patient pre-operatively, the post-op chair time decreases. So that should be the learning from your talk. Beautifully covered everything.
Thank you.
I hope Bharti sir, you're ready, sir, your presentation?
I am already. I was ready before as well. But let me see if I can now.
I think Rahul can help.
Rohit, I
Rohit.
think he has.
Sir, can you please?
Yeah, sir has
Just come
started.
now. Yeah.
It's one slide or the
Multiple
You can
slides.
see the panel.
sorry.
But you have to.
I have to make it like that's better. Now I am.
Yeah, perfect.
Yes. So, good evening, everyone, and I thank Novartis for giving me this opportunity to share this slide, which they have provided. It is newer paradigms in the post-operative management of ocular surgery, combining infection and inflammation. Those are the two factors which are important: the infection and inflammation, and cataract is the most significant cause of blindness in India, and committed to the goal of elimination of avoidable blindness. And likely cataract surgery rates of 6,000 plus per million population is the goal. I think we have already achieved that, and improving quality needs to be emphasized with increasing quantity. And per this okay this okay this yes, so 1.5 million or 6 million cataract operation in developing countries have poor outcomes, and the two most common causes or common reasons of complications are infection and inflammation. So regarding infection, there is infectious endophthalmitis, which is a very serious intraocular inflammatory conditions, occurs within 6 weeks, and severe impairment of vision. And it's because of the peri-operative introduction of organisms. And fortunately, it has got a very low incidence, and out of all US, Europe, and India is the least incidence. Maybe it is less reported or whatever, but we show that our incidence is much less. The causes in United Kingdom, the staph epidermis is the commonest cause. In India, it's nocardia. And 69% positive cultures in post-op endophthalmitis, of which 94% of gram-positive bacteria in our country. So in India, 65% of these people who suffered on endophthalmitis had a visual acuity less than 6/60, which is of course very bad and poor, prognosis. So methods of prophylaxis are preoperative, intraoperative, and postoperative. And out of all the antibiotics available, moxifloxacin is most commonly used and a trustworthy antibiotic to prevent endophthalmitis. The fourth generation fluoroquinolones, the rationale is prophylaxis rapidly attains high level within the cornea and the antechamber, and low ocular toxicity, and high minimum MIC levels in aqueous. So these are the factors why the this moxifloxacin is the antibiotic of choice. Potency of fluoroquinolones for gram-positive pathogens. By rank, moxifloxacin is the best, followed by Gatti, Levo, and it could be ciprofloxacin, ofloxacin as well. And the pathogen against which they are working is staph, strepto, and enterococcus. And also same thing is there with beta hemolytic streptococcus and coagulase negative staph. And Moxi is also very efficient against resistant staph aureus. So Moxi seems to be the most potent against gram-positive pathogens. And mean conjunctival concentration of moxifloxacin is 18 microgram per gram, and conjunctival pharmacokinetics, there is a concentration which is high as compared to other fluoroquinolones available, and that is why this becomes a very effective, and has greater potential against gram positive minimum concentration than gatifloxacin in aqueous humor. So moxifloxacin, the 1.8 is the concentration which is required, and gatifloxacin much less is achieved in the aqueous humor. So that is why moxi seems to be the better bet. The MIC 50 of endophthalmitis isolates in the cases of moxifloxacin, as you can hear, the most potent as compared to older fluoroquinolones, because the incidence of isolates is much less in cases where moxi has been used. And similarly, fluoroquinolone resistance endophthalmitis isolates, the greater its potency is greatest with moxifloxacin as compared to any other fluoroquinolones available in the market now. An ideal topical antibiotic for the treatment of bacterial conjunctivitis must have a rapid rate of kill to minimize the spread of the disease, and there also moxi scores over the other antibiotics available, and it kills Staph aureus faster in vitro than older generation. And in case of inflammation, the early complications are posterior synechia, pupillary block, and acute rise of intraocular pressure, which happens with the inflammation initially. And late, there is posterior capsular opacification in nearly 35%, and cystoid macular edema in about 3% cases. The peak of signs and symptoms of inflammation seen 2 weeks after the surgery, and topical anti-inflammatory treatment after modern cataract surgery elevates the inflammatory response and possible risk for complications such as corneal damage or CME. So corticosteroids or NSAIDs is the question, and corticosteroids seem to be the mainstay of treatment. They have wider range of activity as compared to NSAIDs, and reduces inflammation at multiple points on the inflammatory cascade. The rate of patients with inflammatory symptoms like ciliary flush, pain, and photophobia during the first post-operative months. With the dexamethasone, it's 0/60 in first 3 days, and actually at even 1 month also, it is 0/59 out of 59 cases. There was hardly any patient. With diclofenac, the inflammation increases in the first 1 week and then subsides. In the placebo, of course, there is no effect on inflammatory symptoms. So no inflammatory symptoms after post-op operative administration of dexamethasone, and dexamethasone seems to be the choice as of now. When we compare the prednisolone acetate 1% as to with the dexamethasone 0.1%, it has got, prednisolone has got lesser anti-inflammatory potency and lower glucocorticoid receptor binding capacity, which is higher with dexamethasone, and that is why it is having a longer duration of action. Combating both together, the infection and the inflammation, if we combine, there is a push in compliance is better, and reduces the cost, decreases the complexity of dosing, increased likelihood of receiving the proper dosage, and positively impact clinical outcomes because they both efficacious things are working together. If the two medications are used separately, then 49% is the compliance rate compared to 30% in the 2 medication regimen, and Vigadexa is combating infections and inflammations together. So the indication for Vigadexa is to prevent post-surgical ocular inflammation and infection. 1 drop 4 times a day in the eye to be operated 1 day prior to surgery and 15 days after the surgery. In fact, I use up to 20 days the drug in the same combination. and first and the only ophthalmic self-preserved antibiotic steroid combination. That's another important factor because preservative allergy and preservative reactions are very common in all those drugs where preservative is there. Efficacy and tolerability of combined moxie-dexa formulation for topical prophylaxis and reduction of inflammation in phacoemulsification is very good. And if we compare the efficacy and safety of the combined moxie-dexa versus conventional dosing with moxifloxacin 0.5% and dexamethasone 0.1% for prevention of infection. As I've already said, that the possibility is the results are much better with a combination. Dosing regimens: 1 drop QID, 1 day prior and 15 days after surgery. And primary outcomes regarding ocular pain, acuity, corneal and conjunctival inflammation, antechamber cells, and intraocular pressure was studied. And objective and subjective evaluation at various post-operative time points showed no signs of intraocular infection and minimal inflammation beyond day 3. And adverse effects were mild and similar magnitude regardless of treatment. So that is how the treatment, the patients are symptom-free at day 15 with the Vigadexa as compared to with Vigamox plus Maxidex. And the visual acuity was superior in all these cases who used Vigadexa. And none of the patients in the Vigadexa group reported inflammatory symptoms at day 15 as compared to the combo of 2 drugs. And 3 to 14% patients reported itching throughout the follow-up period. And 1.1% reported itching in Vigamox Maxidex group as compared to 0% with Vigadexa. So this is the beauty of having a zero preservative system, which can lead to all these alleviation of these symptoms. And antechamber cells on day 2, and 96% were observed to have less than 5 cells in antechamber by day 15 with Vigadexa. And as compared to a combo where there were higher number of cells, seen in those cases. IOP was substantially less with Vigadexa as compared to the direct dexamethasone frauds. So single vehicle fixed dose combination of 0.5% Moxie and 0.1% Dexa were found to be as well tolerated and as therapeutically equivalent to conventional separate dosing. And so this is the only self-preserved combination, and it works all bacterial and antifungal, the fungal, causing agents, and that is why it's and compared to the generics, it has got a better drug formulation, and all these points are primarily the bottle and the solution and the preservative, which are not there in the Vigadexa, and that is why this seems to be a better combination totally. Antibiotic efficacy of 4th generation fluoroquinolone moxifloxacin, added anti-inflammatory benefits of dexamethasone, self-preserved combination, well tolerated and comfortable to use, improve patients' adherence to the treatment, and therapeutically equivalent to conventional separate antibiotic and dexamethasone combination makes the combination better and well tolerated, and the patient becomes more compliant. Thank you very much.
Thank you, Dr. Bharati, sir. Wonderful presentation. I do understand, every molecule has its own way of action into surface as well as for intraocular ways. What we have gathered from this combination of steroid and antibiotic in a single dose system, I think one apart from the results which you have shown us, one will be a better compliance from a patient point of view. Instead of two drops of a different bottles, the compliance may be better with a single container. Second is, I think we don't have many preservative-free steroid drops available to us. As Dr. Sridevi was talking about, the ocular surface problems would be much more with the preservatives rather than the actual medications. So this single dose self-preserved medication may be better in that way. That's why I think the visual acuity would also be better with these cases. So I think both for infection and inflammation, I think this would be a good combination if patient can really get to this dosing system. And whatever has been a result, I think it is fantastic to have dexamethasone use, because many of us would be using either a prednisolone type of medications, which has a much more higher penetration. But dexamethasone also in combination has given a good results. Any other comments from the panel?
Sir, I have a question. Are there situations in which you should not use a combination and use them separately, Vigamox or any other moxifloxacin brand, and the steroids for the house, because we have a lot of residents attending? When should we not rely on combination and use individual medications?
Yeah, Dr. Bharti, sir?
The only reason could be when you want to use any one of the ingredients more often as compared to the other. And mostly you want to use steroids more often as compared to the antibiotic in majority of cases when the inflammation is there. And in those cases, it is better to separately use those two ingredients. Another incidents, the other incidents which I am telling now is about the combination getting better if you have fixed dose combination and using it at like in one of my patients, these elderly patients, they confuse in the drops, and I normally want to stop the steroid after 3 weeks totally completely and go on to NSAIDs. And in one of my patients, she continued to use the steroid eye drops for more than 2 weeks, in fact, 5 weeks. And when she came, there was a very high intraocular pressure. So they did not realize that she was using the wrong eye drop. Instead of using a nepafenac eye drop, she continued to use a steroid, and she confused in 2 bottles. So that's another factor which goes in favor of using this thing. But definitely, if you want to use one more than the other, then you have to use a separate, bottles. That will be beneficial, definitely. Thank you.
Yeah. Okay, I think point well taken. Especially those cases where you have a higher chance of inflammation, like a post-uveitic patient, or a post-op you have a lot of inflammation. Then yes, you might go for a separate because you don't require antibiotic to be given too early. Steroid will be required, and those situations you need to go for a separate. Dr. Radhika, is there any comments, Dr. Radhika? No, she's not there.
Point is that actually all the presentations are very clear, and I don't think I have anything to add.
Good. Thank you for being there. Can we have the next presentation now? Thank you, Dr. Bharti, sir.
So meanwhile,
Thank
there
you,
is
sir.
also
Thank you
a
very
question in the chat that, sir, how long do you give Vigadex for? And another thing, you will not taper it. You will stop it at 4 times or 3 times abruptly.
After post-operative, in my all post-operative cases, I don't want to taper it. I want to use Vigadexa for 1 week, and if there's a reason to continue it, which sometimes is about 3 weeks, I continue with Vigadexa 4 times in a day, and then I don't want to taper it. I continue with the non-NSAIDs for another couple of weeks. That's all, and I have no intention of tapering it off in the post-op case, unless there is a reason to taper it off, like in cases where there is a high responder with steroid responder patient. But otherwise, I don't want to taper it off. 3 weeks is a good time, and we can stop it without any tapering it off.
Thank you so much, sir. I now invite the next speaker, Dr. Praful Maharana, who will be covering, I think, the most important topic of the day, how to manage posterior capsular rent. Dr. Praful is Associate Professor at RT Center, and this is a wonderful presentation. I've seen it before. Over to you, sir. Now you're audible and your slides are visible.
Okay, good evening, everyone. So I'll be discussing about management of PCR. So PCR, we all have dealt with this complication in our lifetime. And the the important thing to remember is, the most of the vision threatening problems like GRT, retinal dialysis, they don't occur because of the PCR itself, but because of the panic reaction. And you do all those things like pulling the vitreous, pulling the nucleus, and that lead to more devastating complications. You should always remember this. And if you recognize it early, then the prognosis improves quite significantly. So sudden deepening, momentary dilatation, a clear red reflex, inability to rotate a nucleus, loss of followability, tipping of one pole, and partial descent. These are all the important signs you should always remember. Now, how to plan once you detect a PCR? It depends on three things. First of all, your logistics. Do you have a vitreoretina backup with you or not? Second, what stage, whether it is this beginning of phaco or later stage, I'll come to that, show some videos to you. And lastly, your experience. You have to know your limits, whether you are a SIC surgeon, you are a good phaco surgeon, or you simply moving from ECC to phaco. That also determines how you approach a case of PCR. Whatever may be the stage of PCR, there are few basic things that you should always remember. So one thing is what to do immediately. As you can see here, everything was going fine, but during this stage, during taking the last piece, there was a PCR. So whenever such a thing happens, that the most important thing is don't take out your phaco probe immediately in a jerk reaction. It's always good to take out your second instrument first, then inject some viscoelastic, coat the area of PCR with some dispersive viscoelastic like viscoat, and then form the entry chamber and then come out. If you do this, there is less likely of vitreous prolapse and vitreous loss. So this is what exactly was done in this patient. Once that is being done, then you can take out the residual cortex, do a good vitrectomy, and put an IL in the sulcus. The next important thing to remember is use of viscoelastic. You can see this was the case with a pre-existing PC defect. So once the nucleus matter was removed, you can see initially I am coating the vitreous area, this vitreous interface with dispersive viscoelastic like viscoat, and after that I will put some cohesive viscoelastic like Hilon, so that will push my vitreous interface further posteriorly, and then I'll be able to complete my rest of the part like removing the residual cortical matter using a IA cut mode of my vitrectomy cutter. So use of viscoelastic appropriately is very important to minimize vitreous loss. Third important thing is vitrectomy. Remember, whenever you are entering in, if there is a breach in hyaloid phase and there is vitreous in entry chamber, it's always good to start with cut IA mode. Don't start with IA cut mode. If you do that, then you will create unnecessary traction to the vitreous. Once you are sure that the vitreous is not there, then you can shift on to IA cut mode and take out the residual cortex matter. So once you have done the basic parts, the how to proceed next, well, it depends on two things: what is the size of the nucleus left and whether the vitreous hyaloid phase is breached or not. Vitreous hyaloid phase breach means there is vitreous in AC or not. So if vitreous is not there and you are a confident surgeon, you can proceed with phaco by using appropriate viscoelastic. But if you are not confident enough, it's always better to convert it to ECC. If there is vitreous in entry chamber, the decision making is same, but you have to do a good vitrectomy first. While delivering the nucleus, remember a few things. You have to give some relaxing capsulotomy. If your capsulotomy size is small, no matter how much you try, the natural tendency of the nucleus will be to go down. And always use a vectis to take out the nucleus. Don't use this pressure counter pressure technique. When you're planning to do a phaco, always lower your bottle height and aspiration flow rate. You can use little bit high vacuum so that you don't want to leave the nucleus once it comes to your phaco probe. And phaco power should be depending on the density of the nucleus. If you are doing a phacoemulsification, again with vitreous in entry chamber, first job is to remove all the vitreous. If you are not confident, then you can take the help of triamcinolone acetonide and then proceed with phacoemulsification. All this third section with total or partial descent, it was discussed earlier, but nowadays with advanced vitreoretinal technique, there is no need to go for this. It's always good to close the wound and refer to a vitreoretinal surgeon. So this is one case. So whenever there is a PCR, there are certain things that you should do. There are certain things that you shouldn't do. This is a case where the surgeon did exactly what should be done. So after there is a dividing the nucleus into two half, it was realized that there is a PCR. So the first thing is to put some viscoelastic and bring this nucleus to a safer area. That means away from the area of PCR. Once that is done, it's good to enlarge the wound. And then you take the nucleus out using a vectis. Once the nucleus is out, then you can do a good vitrectomy. And in this case, the sulcus was good enough, so a 6.5 mm PMMA lens was inserted. But this is an example where what you shouldn't do. This was a case where the rhexis was small. You can see 4.5 mm rhexis, and when hydrodissection was attempted, this is the classic case of capsular block syndrome. The pupil snap. You could appreciate here, and then the PC was ruptured. So what should have been done in this case is, again, give some relaxing capsulotomy, try to bring the nucleus to a much safer area out of the capsular bag and enlarge the wound. But on the contrary, the wound was never enlarged, and all the attempt were made to retrieve the nucleus. But as I said earlier, if your capsulotomy size is less, then whenever you are injecting some visco, some fluid, the nucleus has a tendency to go down and down. So in this case, ultimately the nucleus dropped behind. So this is a case, it's a mixture of what you should do and what you should not. It was a case of HMSC. As you can see, during phacoemulsification, midway, there was a tipping of the this superior pole. You can see the nucleus tip, there is the tipping of the pole of this superior pole of the nucleus, and there was vitreous. So the perfect thing the surgeon did is coat the PCR area with viscoelastic, then brought the nucleus above iris to a safer area. Then the wound was enlarged. But this technique you should never do. This pressure counter pressure leads to more vitreous prolapse, and when you can see the vitreous blob here, the ideal way to take out such nucleus is using a vectis. Go in and take out the nucleus, and never forget to coat the endothelium with viscoat before doing that. Once you have taken out, do a good vitrectomy. If you have a vitrectomy cutter machine, use that, or you can use manual scissors also. You can take out the residual cortex matter with bimanual or Simcoe. Even few surgeons are comfortable with that. And then you have to do a good vitrectomy, and you can take out all the cortical matter that is there. Using the IA cut mode, you can put a 3-piece lens in the sulcus if sulcus is there. So this is a case where, again, as I highlighted, it depends on your experience also. You can see phaco could have been done in this patient also, but the surgeon was not that much experienced, and ultimately the phaco was continued, but you can see the nucleus was not coming to the phaco tip, maybe because vitrectomy was incomplete and the irrigation bottle height was too high. So instead of coming to the nucleus, coming to your phaco probe, the nucleus dropped down. So this is what you should never do. This is what is a interface of infinity machine. The bottle height should be 90 or less than that. The vacuum should be low, a little bit on higher side, like 300, so that you don't want to lose the nucleus. Aspiration you can keep at 28 or 30, and torsion or phaco power should be depending on the density of the nucleus. So this is a case. So once you have completed phacoemulsification, it's not that you cannot have rent. You can have rent in IA also, but all these cases are easy to manage because the nucleus has already been removed. So you can see here, while taking out the last fiber, the surgeon had a rent. It was a hybrid technique of IA the surgeon was using, and you can see here when the last fiber was being tried to pulled, you can see there was a triangular PCR, and then the patient squeezed and it become a sulcus to sulcus PCR. So all these cases you can manage nicely. The sulcus is quite good. You do a good vitrectomy. And important thing to remember here, you have to ensure that all the vitreous strand or vitreous that is there in your antechamber is removed. Well, for that you can take the help of either pilocarpine at the end of the procedure or triamcinolone acetonide, and you can also use a cotton stick as the surgeon is doing here to check if any vitreous strand is there. Or you can even sweep using a blunt cannula like Sinski. You can sweep and see whether there are any vitreous strand. Any vitreous strand that is there in wound, you have to take it out using vitrectomy cutter or even scissor also. IOL insertion can also lead to PCR. You have to remember one thing, when you're injecting, the bag should not be overfilled with viscoelastic. and there should not be unexpected pressure while you are pushing the IOL. If there is the pressure is too much, then it's better to come out and reload the IOL rather than pushing it in. But such cases are not that difficult to manage. You have to remove the IOL and then you can put the IOL in the sulcus. And one thing that I have noted through over last few years is that there is always a certain degree of urgency in surgeon's mind to put an IOL. This was a case referred to me by one of the private practitioner. It was a day one post-op. You can see there was a huge rent here, and the bag was there was bag dialysis here, and the IOL was inserted hurriedly. And as I said, you infrastructure also do matter logistics. They didn't have a good vitrectomy machine, so vitrectomy was not complete. So when I took the patient to table, this haptic was inside the jonular dialysis area. This haptic was stuck behind the PC. So, and the entire chamber was filled with vitreous. So managing such cases is not that difficult. You have good vitrectomy machines with you. So my first priority was to secure the haptic, which was there in the dialysis area. Then I did a vitrectomy to take out all the vitreous in interchamber as well as the wound. Then I would avoid dialing such lens. I simply tucked in that haptic into the sulcus. And once that is done, a complete vitrectomy followed by wound hydration was done. So this is another example just to supplement this point. This was a patient. The surgeon called me that there was a dialysis of almost 3 clock hour and the rexis extended in multiple clock hour. So I advise him to please wait for 6 weeks and then refer the patient to me. So when the patient came to me at 6 weeks, you can see there is good adhesion between the intracapsular, the torn part and the PC. And here the dialysis area was there. I think you can see here, but I will do a simple little bit vitrectomy here. And then I have a good supporting plate to put my IOL. So don't be in a hurry to put IOL. If you have a rent, you can always wait for 4 to 6 weeks. Once your bag is fibrous, that will give you a good scaffold to put the IOL in sulcus. This is the last video I'll be showing you. This is from Professor Tushar Agrawal sir. If you have a posterior polar cataract and if you are expert enough in doing PCC, if you do a lot of pediatric cataract surgery, then you can enlarge this convert it into a posterior capsular axis and then put the IOL in the bag. That will give you good visual outcome. So remember, once you have retrieved the nucleus and put an IOL, important part is post-op care. So steroids should be continued for a little bit for a longer period compared to a conventional cataract surgery. Watch closely for the IOP spikes because you have done a lot of manipulation. The IOP may go high and it may also go low also. And retinal screening is a must. Always make a habit of screening the retina at each follow-up. And this is what I teach all my residents. Don't do any heroics, no knee-jerk response. Always call one of your senior if you are under pressure. Don't use pressure counter pressure technique. It's always used to go in with a vectis and take the nucleus. Don't let your chamber collapse. Prefer bimanual or Simcoe cannula. And lastly, anything that is out of your range, please don't chase it. You will always land up in trouble. With this, I'll conclude my talk. Thank you very much for the kind listening.
Thank you, Praful. It was a beautiful presentation as usual. You are the master in producing PCR and managing also. But whatever video you have shown, they were classically managed. I think the points you have, this last slide, which is still visible, is really tells everything so clearly. People should remember this. And I hope that, people will manage the PCR effectively. Well-managed PCR is, goes long way in better outcome for these patients rather than complicating the issue. I think I like one point you said, don't be in hurry in implantation IOL. I think that's a very, very critical point. We sometimes, despite knowing that you don't have a good space, we still put the IOL and you have a lot of complication because of that. I think all the points are beautifully covered. Any comments, Dr. Radhika?
Yeah, I think it's very important, as you said, that if supposing at the end you feel that there is not adequate stability to put an IOL, then you can always plan as a second stage later on. And one more technique which is useful is the scaffold technique, where you can bring the nucleus anteriorly and the lens matter anteriorly. Then you could put the IOL sometimes that can also help to stabilize it, and then you can complete the surgery. But of course, it will depend upon how much residual lens matter there is, and there shouldn't be any vitreous, etc. So, but that's another, just to complete the list of things that can be done.
Yeah, I think that's a good point. Dr. Parful, please incorporate this video also next time. And other, I think you should add is, the anterior capsular tear extending to posterior capsule, and then having problems like many of the difficult scenarios are there. That will complete the scenarios. Okay, thank you, Parful. Yeah, thank you, Parful.
Thank you, sir.
I now invite Dr. Tinku Bali, who will be covering where we stand today and on cystoid macular edema. Over to you, ma'am. She is a prolific vitreoretina surgeon at Gangaram Eye Hospital and has had training from LVPI amongst a host of other institutes.
Yeah, I'll just share my screen. Is my screen visible?
Yes, visible. You can go into the slide show mode.
All right. Yeah, so I'll be talking about a common complication of cataract surgery, that is cystoid macular edema. And as Dr. Sridevi mentioned, it can cause a very unhappy patient even after a very perfectly done cataract surgery. Well, it can occur even after uneventful cataract surgery, but the incidence of a cystoid macular edema rapidly increases after a complicated cataract surgery. Now, the overall incidence in the Indian subcontinent would be 2% of patients would have cystoid macular edema, even following an uncomplicated cataract surgery. That would give us around a substantial amount of cases per year. And geographic CME would be around 20% of cases with an uncomplicated cataract surgery. Now, a clinical CME would be a symptomatic loss of vision, or that when the patient has a vision of 6/12 or worse, and loss in the best corrected near visual acuity and loss of contrast. And angiographic CME is a different entity altogether when it is seen more on angiography. I'll be talking about it a bit later, and may not correlate with the vision. Now, the incidence in Indian patients with diabetes is 47% of eyes without pre-existing diabetic retinopathy would have CME, and 55% of eyes with a pre-existing diabetic retinopathy would have CME. The pathophysiology of CME is a disruption of the blood-retinal barrier. The most common cause of this disruption is surgical inflammation. So this inflammation causes release of prostaglandins in the aqueous. These then migrate to the posterior chamber. This causes a breakdown in the blood-retinal barrier. And this breakdown of the blood-retinal barrier causes leakage from the perifoveal retinal capillaries, accumulation of fluid within the intracellular spaces of the retina, and development of CME. So inflammation due to surgical manipulation is the major cause of CME. The other causes would be aging changes, systemic vasculopathies like hypertensive retinopathy, and diabetic changes. Now, angiographics, there's a lot of heterogeneity in the classification of cystoid macular edema. It is classified as angiographic, as clinical, in some studies on the basis of OCT. So angiographic CME is defined by the presence of fluorescein leakage, and clinical CME by a decrease in vision, and it is also seen by edema and level 4 when there's severe perifoveal edema. This edema extending to around 1.5 disc diameters, this classic petalloid pattern, and you may also see a hot disc, that is a hyperfluorescent disc on angiography. The other way to classify cystoid macular edema is an acute cystoid macular edema, which occurs within 4 months of surgery, late onset, which is rarer but can occur, and this occurs more than 4 months postoperatively. Chronic CME is one that lasts more than 6 months, and a recurrent CME, which occurs again and again once you've treated it. The symptoms would be a decrease in visual acuity, loss of contrast and color vision, and metamorphopsia, which the patient would appreciate on an Amsler's chart. The signs would be retinal thickening. Whenever the retinal thickening is more than 300 microns, you would be able to see it when you do a biomicroscopy, and this is better seen with green light. You will see a loss of the foveal reflex, and you could actually see the petalloid spaces. However, if the edema is less than 300 microns, then you would obviously see it only on the OCT. There could also be mild vitritis and swelling of the optic nerve head. Now, the signs and symptoms of cystoid macular edema after a cataract surgery develop within the first month to the first 3 months, that is within 4 to 12 weeks. And the peak time for this to occur is 4 to 6 weeks after surgery. So the patient would have a very good vision in the first month and suddenly would come to you a month later and say that now suddenly I feel my vision is going down, my vision is distorted. And that is the time, especially in a diabetic patient, that you would suspect a CME is occurring. So the risk factors for CME are systemic diseases, pre-existing ocular conditions, and intraoperative complications. So identifying the risk factors for CME is crucial for the prevention and for the adequate treatment. Now, diabetes, as I mentioned before, it promotes a CME even in the absence of diabetic retinopathy. So clinically significant cystoid macular edema could be seen in as many as 1.7 to 3.5% of diabetics, even without retinopathy. Systemic hypertension, again, is a risk factor for CME. The other risk factors are retinal vein occlusion, previously existing retinal vein occlusion, glaucoma, vitreoretinal interface disorders such as epiretinal membranes, vitreomacular traction, pre-existing uveitis. And of course, the most important are the intraoperative factors like a PCT, vitreous loss, incarcerated vitreous in the incision, cortical remnants in the vitreous, trauma of the iris, dislocation of the lens, iris fixated or an anterior chamber intraocular lens, and a posterior YAG laser capsulotomy, which has been done very early on after cataract surgery. Now, just to reiterate, diabetes is one of the most important risk factors for the development of CME, and macular changes are more likely to occur after cataract surgery in patients with diabetes, especially in those with a pre-existing retinopathy as compared to those without diabetes. And this has been a very large study in the Indian scenario, which was published in BJO. And here you see that in patients with diabetes mellitus, there was a 51% patients had an incidence of CME, and this is most likely a combination of angiographic and clinical CME, as opposed to 21% patients without diabetes mellitus. So there was a 2.4 times increased incidence of cystoid macular edema in Indian patients with diabetes, as opposed to their non-diabetic counterparts. Now, when we compare patients with diabetic retinopathy and patients without diabetic retinopathy, these are all diabetics, but some have diabetic retinopathy and the others don't. So the incidence of CME is almost the same. That is 47% in patients without retinopathy and 54.8% in patients with diabetic retinopathy. So even if the patient does not have diabetic retinopathy, he is at a risk for developing CME. Now, the diagnosis of CME can be done either by the fluorescein angiography. The OCT now is most prominently used for the diagnosis, and autofluorescence. So the classic petaloid picture on angiography. The OCT reveals either a diffuse macular edema or cystic spaces in the inner nuclear layer and the outer plexiform layer. So here you see in the outer plexiform layer, you have these large elongated cysts, and in the inner nuclear layer, you have small round cystic cavities. And quite often there is also a neurosensory detachment under the fovea. The management of CME. So in the management of CME, the prophylaxis is the most important thing that we can do. That is not allow cystoid macular edema to occur. After that, prevention is by doing a very atraumatic surgery. Medical therapy includes NSAIDs, corticosteroids, and anti-VEGFs. And surgical cases are the ones where there is traction. So those are the cases with VMT or epiretinal.
Is there a connection loss or is it only my internet?
No, there's a connection loss. I can't hear.
Yeah. Dr. Tinku, if you can hear us, your slides are not moving and you're not audible any longer. I think. Okay. So.
Oh yeah, hello.
Yeah,
Sorry.
I think you'll need to reshare. Yeah.
Yeah, are my slides visible?
No, ma'am, you'll have to reshare.
Oh, I'm so
We lost
sorry.
the connection. Yeah.
Oh. Now?
Yeah, it's
Yeah,
there.
they're visible.
Okay, I'm so sorry. So, yeah, so as I mentioned before, prophylaxis is the most important way to treat this condition. Moving. Just give me a minute. I'll just share again.
Yeah. Meanwhile, Sir Professor Tityal, in premium intraocular lenses, would you recommend using all these NSAIDs routinely, or should they be reserved for certain conditions only?
Yeah, I think it's coming. Can I continue?
Yeah, please do.
So yeah, just talking about the prophylaxis, the inhibition of the inflammatory cascade is a core strategy for CME reduction. And prophylaxis should be considered in high-risk patients, like patients with diabetes, patients who've already had CME in the fellow eyes, patients who've had uveitis, venous occlusions, who have had intraoperative complications, also patients who have cardiovascular diseases, and patients taking prostaglandin analogs for glaucoma. So these are the patients where we should consider prophylactic measures. Now, Nepafenac is an excellent drug for the prophylaxis of cystoid macular edema. Now, how does it work? So Nepafenac is a drug which rapidly penetrates into the cornea and the sclera and is converted into Amphenac. Now, both Nepafenac and Amphenac, they inhibit prostaglandin H synthase, that is a cyclooxygenase, which is the enzyme required for prostaglandin's production. And this blocks the inflammation-mediated breakdown of the blood-retinal barrier and causes a reduction in the postoperative CME. There have been multiple studies published recently which have, assessed the role of Nepafenac 0.3% after cataract surgery, and they all have shown that they have been very efficacious in reducing post-op CME, especially in patients with diabetes, as compared to placebo. Now, this is a very interesting chart which was published in JCRS, which shows the aqueous concentrations of different NSAIDs. And as you can see here, Nepafenac penetrates very early on and has a very high aqueous concentration and penetrates very early on. That is, even at half an hour, it has a very high aqueous concentration. And then when you combine it with Amphenac, so both the drugs together maintain their concentration for as much as up to 4 hours as compared to the other NSAIDs like Ketorolac and Bromphenic. So excellent corneal penetration and excellent maintenance of the aqueous concentration. So Elevro by Novartis is 0.3% Nepafenac, which can be given prophylactically, especially in high-risk patients. So this has to be started 1 day before cataract surgery and continued till around 60 days post-op. And this reduces the risk of post-operative macular edema, improves the BCVA, and has no anticipated safety concerns. I actually, in my practice, in diabetics, do use it even for 90 days post-op. And it works very well. So it has a better availability because the particle size is extremely small. The particle size is 40% of the size found in the 0.1% Nepafenac. That is why it has excellent bioavailability. And the recommended dose of Elevro is to give a drop of Elevro in the conjunctival sac of the affected eye once a day, beginning 1 day prior to cataract surgery. It has to be given on the day of surgery and up to 60 days of the post-operative period. And an additional drop should be administered 30 to 120 minutes before surgery. This drug also helps in excellent prevention of pain and inflammation. And for pain and inflammation, you can give it only in the first 2 weeks. These are non-high-risk patients. For the prevention of pain, you can give it in the first 2 weeks, and an additional drop should be given just prior to surgery, half an hour prior to surgery. For the medical management of postoperative cystoid macular edema, again, NSAIDs inhibit the cyclooxygenate pathway and decrease the production of prostaglandins. Corticosteroids, either topical, periocular, systemic, or intravitreal, again, are excellent for recalcitrant cases, and anti-VEGF agents can also be given in cases which are non-responsive. So this was a patient, an 85-year-old male who had cystoid macular edema 3 months post-op. There's a vision of 636. This is during COVID times. He could not come for a follow-up. So I started him on Nepafenac eye drops, that is Elevro eye drop once a day. And 8 weeks later, you see his vision came down to 6/9. This was again a diabetic patient, cystoid space here, but causing him a lot of distortion, vision of 6/9, but a very unhappy patient. 4 weeks after using Elevro eye drops, you see that this cystoid space has disappeared. Patient has a 6/6 vision and was a happy patient. Surgical management, like I said, pars plana vitrectomy can be used to relieve traction in cases with VMT or epiretinal membranes. And Nd:YAG laser can also relieve tractional components such as any vitreous which is adhered to the iris or any vitreous which is in the wound and causing chronic traction. So the current challenges in the Indian scenario with these drugs, the drugs are available to us, but the challenges are patient compliance. Now, patient compliance has become much better once you're giving once a day dosing with Elevro eye drops. Standardized treatment protocols are not there, so different surgeons use different protocols. And availability, of course, is a challenge, but now the availability also is much better. In most of the cities, these drugs are available. So to conclude, pseudophakic cystoid macular edema generally develops a few weeks after cataract surgery. Normal visual acuity does not exclude a CME. Near visual acuity and contrast sensitivity are more important parameters. Diabetics with or without retinopathy have a high incidence of CME. Prophylactic treatment with Nepafenac must be started in high-risk diabetics. And once a day, Elevro eye drops are excellent because of the excellent patient compliance. Early treatment is mandatory to avoid permanent structural damage to the photoreceptors, and surgical treatment has a role in chronic CME. Thank you so much.
Thank you, ma'am. Sir, you're muted, sir. Professor Tutyal, sir. Yeah.
Thank you. Thank you very much, Dr. Tinku. It was a very nice presentation. I think we all understand the importance of NSAIDs in cataract surgery and the use of these medications, as you said, prophylactically in the high-risk cases, even for normal cases also, because they can also develop CME.
Yes.
And use of these medications are, I think, more important than steroids, in fact, for preventing the patient suffering from a visual disturbance happening because of uncomplicated surgery also. Beautifully covered. Any comments from the panel? Dr. Parful? Dr. Radhika, please.
I think the topic was very beautifully covered, and knowing which are patients at risk is important. Plus, mentioning the issue of YAG capsulotomy was also important. People need to take that into mind. Otherwise, everything will be covered. And the NSAIDs, earlier there was some fear of using them, but that was a particular type. And the modern NSAIDs are very safe to use. Earlier, there was a little bit of a concern about corneal melting, etc., but that is not so with the newer formulations.
Yeah, especially with once a day dosing, I don't think that is so much of a concern now.
Yes.
I think the compliance factor is one of the important things, because what has been going through the in the management point of view, we all say there was a time some surgeons said no drop post-op. You do surgery and go for your work. So those are concepts sometimes go in the mind of people also. Very, like they'll say, I'll use drug for only 1 week or 2 weeks. So that is not important how long we use. It has to be effective use of these medications to prevent the unnecessary complication coming up these cases. And we understand extra drugs should not be given, but some drugs are required. If I see my own practice, I use these NSAID in all post-op patients, even for a normal patients. That Dr. Manpreet was asking. For a premium oil also, as soon as we taper the steroids, something has to be there. So my NSAIDs are there from day one. and goes on for at least 8 weeks minimum. So that once we stop the steroid, they also cover further, as you rightly said, Dr. Tinku. Sometimes the CME will occur after you stop the steroids. Then the patient has a visual disturbance coming up. So it is better to cover them for a longer period. 8 weeks is the, I think, good period. Sometimes a diabetic patient, uveitic patient, you might go on for a next 4 weeks also. So 12 weeks coverage will cover the initial 3 months window period, which patient can have a significantly higher clinical CME also. There will be a definite macular edema happening in these cases, which is picked up by the OCT. But the clinically visually significant CME is also there, and that has to be taken into consideration also. Don't neglect the patient, as Dr. Sridevi was talking about, with the visual disturbance coming in a posterior period. That may have an alarming sign for a serious thing coming up. We do see patient coming say, I'm not seeing well, I was seeing well before. So you have to be very careful in these patients to assess them right from the ocular surface to the macula. I think that is important for a pre-op surgery also and post-op also. Yeah, any other comments? The young people sitting here.
Any preference for the type of NSAID, Nepafenac, Bromofenac? We have a lot.
Yeah, I think there are many of them are available. Nepafenac has been there for a long time. We have been using that for so many years. It's initially the TDS dosing. Now we have Elabro, which gives a single OD dosing. That has made things more simpler. I think the availability was an issue in the beginning. Now it is available freely everywhere. I hope the cost will also come down from the Novartis point of view, which makes things easily available. But looking onto the penetration, one is the penetration in the aqueous, that is through the cornea. One is the concentration in the vitreous. Because once we talk about CME treatment, then we require a more concentration in the posterior part. There, I think, we don't have a proper study, but I feel if I see the literature, Bromfenic may have a slight advantage there, having the more posterior penetration in these cases. But as far as the treatment of CME is concerned, I think Nepafenic is the preferred drug for all of our cases. I remember I've done a double-blind study of a Nepafenic versus placebo in post-phacoemulsification in non-diabetic patients. There also we had 2% of cases developing clinically significant CME within 3 months. And we realized those patients who were in the group where Nepafenic was given, there was an automatic resolution of macular edema which was there in these patients, and the vision improved subsequently. So that is the advantage of covering these patients with the NSAID, because there'll be a invisible inflammation going on in a post-op cases. Even with a small incision, this does happen in most cases. So I think that's a very effective way of managing. Only thing, I think the ocular surface that Dr. Radhika rightly pointed out, ocular surface has to be managed appropriately, though don't forget giving the lubricant drops for these patients for long time. Yeah, any other comments?
Yeah, Dr. Tinku, I have one question for you. I operate a lot of cases of preparatory cataract. In those patients, they have CME to begin with, and after cataract surgery, the PRP and all these things are done. So what's your approach for such patients who have already CME and you are operating?
Patients who already have CME, I would first like to treat the edema before taking these patients for surgery. So either with anti-VEGFs or with intravitreal dexamethasone implant. And in case the patient, if there's an emergency, patient is bilaterally blind, then I sometimes could combine the cataract surgery with an anti-VEGF or a steroid injection. Yeah, but
any role of PST? People even give PST on the same setting.
PST also works, but now that we have intravitreal dexamethasone, generally we tend to favor that. But yeah, if not available or if cost is an issue, then PST also does work, though the response is a bit slower as compared to intravitreal dexamethasone or anti-VEGFs.
Thank you.
It may work, yeah.
Okay. I think we might conclude here also. I would like to thank on behalf of the faculty of RP Center, and people who have joined today virtually for this CME on cataract. I think we covered almost all the important aspects, right from the use of IOCT for highlighting various important steps of surgery, subluxated cataract management, and looking on to one of the most important topic of ocular surface and unhappy patients. Then titrating the good outcome of a toric IOLs, what all things are important. I think the basic aspect of cataract surgery was beautifully covered, and subsequently looking into a complication-related thing, and PCR is a major complication, and Dr. Praful beautifully highlighted most important, steps where complication can occur. I forgot to highlight, I didn't stop you in that video where it showed that pupillary synapse sign, and the surgeon was doing a hydro procedure from the side port in that particular case, and that built the pressure inside. To never do a hydro procedure from side port, it should be done from the main port, so that whatever pressure rises there because of viscoelastic, it will come out, apart from the small capsulorhexis which was there in that particular case. And the subsequently post-op CME is major important aspect. We covered that part also, and covering the anti-inflammatory, anti-infective medication as a combination. Vigadex may be a better option for those patients where we don't require to give steroids for a longer period. Otherwise, I think better option for us is to give a separate dosing for a long time. But in Indian scenario, sometimes people like to have a simpler way of putting drop, like Elevero, where you have to put only one drop rather than 3 times a day. Maybe that's a good concept people have picked up, so that compliance also increases. So we like to thank Novartis also for coming out with the academic program like this. We hope that they also support many more academic programs with our Ophthalmic Research Association. Again, like to thank both our guest speakers, though they are from our own Delhi, part of our Delhi organization. Both Tinku and Dr. Bharti has been there for many, many times. I'd like to thank the office bearers of Ophthalmic Research Association and all the speakers. Done a wonderful job today. And all the people who are listening to us, if they have any queries, they can always mail us. We'll be there to answer their queries also. Thank you and good night, all of you, and wish you very, very happy New Year, because this will be the last webinar before the New Year. So wish everybody that they should have a bright and beautiful 2023 without the COVID coming up.
Thank you, sir.
Okay. Thank you. Much
night.
needed. Thank you, sir.
One photograph, sir, before everyone leaves.
Oh yeah.
Yeah.
Let's have
all the finishers. Yeah. So 1, 2, 3, smile. Thank you.
Okay.
Thank you.
I think you had a brightest smile,
Always.
Okay. Thank you and good night.
Bye. Thank you. Good night.
Thank you.
Good night, everyone.
Good night.
Good night, sir.
Yeah. So I think we had a good presentation discussion. Please, Manpreet, put up that. I think we are offline.
Yes, sir. No, sir, we are not offline. So I'll do that. Yes, sir.
Rohit?
Can we be offline, Rohit, to
Sir,
the attendees as well?
just give me a second. I'm doing.
Yeah.